Hi, this is Dr. Carol Zaher. I'm one of the co-chairs of the Right Care Initiative and the LA University of Best Practices. Welcome, everyone. We're glad to see such a wonderful attendance this morning. As things in life tend to change, and one of the things we do or try to do in the Right Care Initiative is manage change and change management. So we are experiencing that today with the issues that we have in the world going on. That said, I would like to let you know Dr. Carol Peden is here, correct, Carol? Who's one of our co-chairs as well. Dr. Tony Kuo and Dr. Steve Chen, I don't believe are available at the moment, but they are also co-chairs. And if they join us later, we might get some updates from them. But I would like to welcome you all. And as you see a little message there that if you have any problems with technical difficulties, as we say, you can either message Alissa or Brian, and we can try to help you resolve those. And at either during the discussions and or afterwards, there'll be a time for questions. So you have a chat box at the bottom of your screen, and you can submit a question in that format, and then we'll pass that along to the speaker. So with that, we're going to try to stick by our timelines. We have a lot of topics today, very interesting ones and quite different. So I'd like to pass the chair upon to Hattie to make some opening remarks and to introduce our first speaker. Hattie, are you there?
Our remote meeting today. And thank you, Drs. Flynn and Emmons, for encouraging us all to establish online capacity, which is proving essential in this public health emergency. We do have 65 people online at the moment, which is remarkable, and I appreciate everybody signing on early. I will skip our regular state updates, except to say that yesterday, several of us in the Right Care family were on a conference call with the head of cardiovascular disease for the Centers for Disease Control, and we really appreciate their inviting us to be part of their hypertension national roundtable. It turns out that hypertension and cardiovascular disease and diabetes are very important comorbidities in this COVID-19 pandemic. So I want to skip further remarks to give our dear Capital Region Chairman, UC Davis cardiologist, Dr. Bill Bommer, as much time as possible for his presentation on the nexus between COVID-19 and cardiovascular disease and diabetes. Dr. Bommer, thank you so much for joining us today. Bill, can you get audio? Can we give Bill audio?
Good morning and welcome everyone to this remote meeting for the importance of cardiovascular disease to our healthcare professions, our patients, our families as well. If I could have my first slide. There we go. Today we are in the position which we thought we would not be 2 months ago of discussing a priority item, which is COVID-19. In our patients with cardiovascular disease, it's now an important aspect. Next slide. So COVID-19 is now declared by WHO a pandemic. Here showing in the colored areas the countries that are currently involved, and they are growing on a day-by-day basis. It is throughout the world at this point in time, in most countries and in all continents, with the exception of Antarctica. So it is a global pandemic with the new virus or novel virus, which the disease has been called COVID-19. Next slide. So this stands for a coronavirus, a novel coronavirus that appeared in a small area of Hubei in China, a small area of a Western market near a healthcare area at the time, and has rapidly spread throughout China and now throughout the rest of the world, being in almost all of the countries in the world today, showing a relatively high mortality for a virus at 2 to 3% in the early studies that were done with it, affecting a large number of individuals, especially the elderly, presenting with primarily fever, cough, and myalgias, as seen in the bottom of the slide. So that is one of the measures we can use to detect it, is actually temperature or fever, which is being used to try to isolate this disease. The problem with this disease is, even though the overall mortality is 2 to 3%, in older individuals, it goes to 8 to 15% as people get 70 or 80 years of age. Next slide. So this shows a relative proportion as of yesterday for the number of cases and deaths in the United States, with about 1,257 cases and at least 38 deaths in the US. This obviously is going up. We've updated this slide 3 times in the last 4 days, just showing how rapid it grows. Now, what this slide shows is that the overall incidence of disease for heart disease, stroke, and influenza is much higher. And the mortality from those diseases absolutely is much higher for heart disease, stroke, and for influenza than it is for COVID-19 in the United States at this time. So we have to not forget that heart disease, stroke are still the #1 killers in the United States. As we focus on COVID-19, however, we realize that COVID-19 is an epidemic, a pandemic, increasing rapidly, and these cases will go up, and it preferentially infects and kills individuals with cardiovascular disease. So there's a relationship between the bars on the right of the screen and the bars on the left. They interact. So this interaction is what we're seeing today, and we have to be careful about. Next slide. So again, this just shows in a little more detail the mortality from heart disease, stroke, and COVID-19. COVID-19 is small on this scale, but increasing. And the reason to show this is, let's not forget about our patients and the diseases of cardiovascular disease, heart attacks, and strokes, while we're also focusing on COVID-19. Both are important, and as we said, the relationship between the two is increasing. Next slide. So this shows that not only being in the world, it is in almost every state in the United States at this point in time. And we are here in California, which is one of the 3 highest prevalent states in the US. Washington, California, and New York are the 2 prevalent, but it exists in most states in the US, and we expect it to increase in all of those states as well as in California. Next slide. So this slide just shows that we do have, for the bottom 3 rows, we do have prevention capability, reducing risk factors, cholesterol, blood pressure, for heart disease, stroke, as we go along. We do have also treatments if someone comes in with an acute heart attack or stroke that can reduce or ameliorate their risk and their mortality at that time. So we have both prevention and treatment. We have that as well for influenza. But when we go to the top row, we see for COVID-19, at this time, we have very little preventive medicines or inoculations that are available, and we have very little actual proven treatments for the disease. So we're still in the unknown as far as our capability. And that's why this disease appears to be spreading rapidly, because we have literally zero or little prevention or control that can be easily rolled out for this disease. Next slide. So the typical recommendations for hygiene and isolation are endorsed by the Right Care Initiative, including covering your cough and sneeze, since aerosol dispersal is probably one of the prime ways of infection with this disease. Washing your hands more regularly is recommended, multiple times a day, and to avoid contact by shaking hands with others, which may be a vector of germ transmission. Next slide. Obviously, get a flu shot, because we still have a significant influence from influenza. And this, in fact, is a rapidly progressive disease that can kill people. As many as 0.2% of individuals with influenza could die from this. So get an influenza shot if you have not already had one. For the idea that isolation or self-isolation may be required for societies or groups, it is wise to have several weeks of supplies on hand. The incubation period may be anywhere from 14 days as high as 27 days in some small cases. So you should have 2 weeks to a month of supplies available if you were required to self-isolate. Because temperature is present in 99% of these individuals, measuring temperature is an important measure or indicator of the presence of disease before testing is available. Next slide. So what is COVID-19? The virus shown in the upper corner gets into the body. The little appendages on the side, or the spikes of it, actually attach to the ACE receptor on the cells of your vascular cells and your myocardium and your other organs. By, in fact, linking with the ACE receptor, it then allows it to invaginate into the cell and be brought into the cell. Once into the cell, it turns on your own RNA to start manufacturing repetitive copies of the virus that then overwhelm the cell. And when the cell dies or is injured, it leaks out into the circulation. And that is how the cell replicates itself. You, the host, are doing the actual replication for it. Since it is present throughout the vascular system and organs of the body, it does increase the risk. We do know that other viruses, in fact, populate into the vasculature, get into inflammatory areas of plaque and vulnerable plaque, and may contribute to rupture of the plaque, which could lead to acute coronary syndromes. And increased acute coronary syndromes are seen with viral illnesses, including COVID-19. Because it also invades the myocardium, there is, in fact, depression of myocardial contraction, and heart failure can occur in those individuals. And since it, in fact, involves the organs of the body, it also affects or reduces ion channel conduction and may lead to acute arrhythmias because of acute inflammation in the heart. Next slide. Our recommendations are based on what we see in at least case reports for this disease. We see that 16% of individuals will have arrhythmias, 7% will have acute cardiac failure or injury, and we also note there is acute heart failure, myocardial infarction, myocarditis, and cardiac arrest associated with this disease. Obviously, the individuals who come in have both respiratory and cardiac problems with this. In cardiology, and healthcare professionals will have to be prepared for this. In severe cases of either respiratory or cardiac failure, there may be need to access VV or VA ECMO for extracorporeal circulation in these individuals, and cardiology teams will need to, in fact, be available to place some of these catheters for the very severe and sick individuals for that. For individuals with heart failure or arrhythmias or EKG changes, echocardiography is recommended by the ACC to evaluate LV function. Next slide. And so what, in summary, do we have for this disease? A pandemic at this time with a 2 to 3% mortality, depending on which country we're looking at. Remember that 80% of individuals will have mild or moderate symptoms and will not require necessarily hospitalization for that. However, in the elderly, we see up to a 15% mortality in the trials that have been done for this. And so we need to be especially aware of that. And at the bottom, what we see is for individuals with comorbid disease or already pre-existent disease of cancer, hypertension, chronic lung disease, or diabetes, this is going to triple the mortality in that group to about 6%. And those with cardiovascular disease, the rate goes up about 5 times to about 10% in those individuals with existing cardiovascular disease. Next slide. So the ACC, the American College of Cardiology, recommends a number of things, still trying to isolate individuals so we don't infect everyone on our service if someone comes in with this disease for that. Get vaccines as needed for those individuals. And because contact is so infectious at this time, perhaps some of our individuals should have telemedicine or telephone contact rather than coming into an office with other sick individuals or patients. And lastly, for the patient who comes in for heart failure to the ER, viral therapies often mean hanging up 1 or 2 liters of fluid and running it in for somebody with an acute viral syndrome. But in this case, this may exacerbate heart failure, so cautious and careful monitoring of fluid is required in the ER. Do not just run up 1 or 2 liters of fluid once those individuals come in, and be careful to make sure your patients as outpatients get adequate sleep, rest, and eating nutrition. Next slide. And this is the actual virus as I show here. The spikes here are in fact the things that link to the ACE receptor, and that allows them to enter into the cell where you as a host manufacture them. Next slide. What we show here on the top is the really lethal viruses. If we look at those that are listed in the top 2 rows there, these kill 80 to 90% of individuals, include rabies, smallpox, HIV, Ebola, rotavirus, dengue, hanta, and Marburg. These are very deadly diseases. At the bottom, we have some COVID viruses, and to the bottom right is influenza. Now, the importance of this is the ones on the top are highly fatal and deadly. The ones on the bottom, that is influenza, is less deadly at about 0.2%. Where does COVID-19 fit in this? It is right about in the middle in the dark area. It is 20 times more deadly than influenza, but yet it is 20 times less deadly than the smallpox and the rabies that are seen on the top. So it's intermediate as far as lethality. Next slide. This slide shows the infection rate, and you see COVID-19 in the middle there. After each case, we estimate 2.5 individuals will be infected from that index case. Obviously, this is more infectious than is influenza, Ebola, or MERS, which have lower infection rates on the top, but less so than measles, smallpox, and rubella, which are shown on the bottom. So it is intermediate lethality, and here we see intermediate infection rate for this disease. It happens to fall in the sweet spot, next slide, where being intermediate, it can infect a lot of people, not kill off its host necessarily, but because it's very infectious, can be in fact communicated to a lot of other individuals. And this is what we see from the worldwide data shown here. The red line and pink on the top are from China, showing the infection rate and mortality. The blue line and the aqua line show the infection rate and mortality in the rest of the world. Now, what we see in China, under extreme levels of hygiene and quarantine, where they were actually locking the doors to lock people in their houses so they could not get out, we see some control with a tapering or a flattening out of the curve of both infections and mortality. That is much more difficult to occur or to develop in the rest of the world. And we see for the rest of the world, both the infection rate and the mortality are continuing to go up in a relatively steep area. So we see that this is, in the rest of the world, rising rapidly at this point in time, showing that it is a pandemic. And despite hygiene and quarantine in the rest of the world, we see a rapid increase in it at this point in time. Next slide. And this is now the last slide that we have. And what we show basically here is we are continuing to use what we have as tools, which are hygiene and isolation and quarantine at this time in the state of California. As of yesterday, the CDPH, of which we work with closely and we want to, in fact, recommend what they're using, has come out with this announcement through the governor to avoid social contact. That is meaning avoiding large meetings, and to distance yourself, even at small meetings, to at least 6 feet away for this. These are current recommendations at this point in time. They will have vast implications for our society as we go along. And as you know, we are seeing both healthcare, social, and economic consequences to this. It remains to be seen whether California hospitals will be exposed to an increase in the prevalence and the incidence of this disease, and whether this surge can be handled by our current healthcare system. The good news is that in 1 or 2 years, this will have probably gone away. The bad news is this epidemic will get worse before it gets better. And with that, I'd like to thank everyone for attending. We look forward to this, and I'd like to turn it over to, I think, Alissa at this point in time for the continuation of our meeting.
All right, Dr. Zaher, thank you very much, Dr. Bommer. That was very interesting, especially from my perspective, even as a cardiologist, to understand some of the maybe additional risks and how the virus acts. So thank you. I realize you were very kind to fit some time into your busy schedule for us, and we really appreciate that. And so appreciate your time. Thank you. We don't really have time for questions at this point, so we will move on to Alissa Maier's talk on prediabetes and diabetes, which is another burgeoning problem we have in the United States as well. Hopefully Alissa will share some insights for how we can make some change management there. And now at the end of Alissa's talk, we will have hopefully some time for questions and answers. Alissa?
Can you guys hear me okay?
Yes.
All right. Megan, can you give me control of the screen? All right, just make sure I have control. It's not letting me next slides. Okay, now it seems to be working. That's not you doing that, Megan? Okay. Well, thanks for bearing with me there for a second as I made sure I had control of the slides. But thank you, Carol, for the introduction. And this is definitely a topic that is very near and dear to my heart for several reasons. But my name is Alissa Maier, and I am with the Gare Center for Health Systems Science and Innovation. I work along with Dr. Carol Peden, who you all know very well. So the Gare Center for Health Systems Science and Innovation is something that many of you are probably not familiar with yet. So we're a pretty small team of staff and faculty, and we work in the space of implementation science, research, and projects. So our mission is to help collaborating health systems deliver better, more efficient care and to learn about the science of healthcare delivery in the process. And our vision is to promote high quality, evidence-based and equitable care through improvement science, education, and advocacy. So I want to talk a little bit about my inspiration for this work that I have been doing now for about 7 years. And so this is a picture of me and my mom. My mom was raised in the South. She struggled with weight her entire life. And as someone who works in the diabetes space, I've been encouraging her to make some lifestyle changes for years and encouraging her to get her A1C checked. And she had always told me for years that she gets her, her routine work done, and that her primary care physician, who she's gone to for decades, has always told her that her numbers are doing really well for someone her size, but her doctor does routinely recommend that she make some lifestyle change, though she never has been consistent with that. And so I finally was able to get her A1C results about a year or two ago, and it was 6.3, which is the top limit for prediabetes. And she had said, oh no, it's fine, I've been at that number for years. Which was very concerning to me to hear that her primary care physician had been telling her for years that an A1C of 6.3 was fine. And so she was at this number for a number of years, and then I got a call in March of last year that she got her A1C checked again, and she was up to 6.9, and then her doctor told her, oh, you have diabetes. And so these are just a couple of her values. So her BMI was 50.1, a weight over 300, and her A1C had jumped up to 6.9. Now, mind you, her father also has had diabetes for years, so she does have a family history of this. So you can see her numbers are not looking great. And so after working with the Right Care Initiative, I was sort of looking at these numbers and her recent diagnosis of diabetes and became concerned and learned about the coronary artery calcium score. And if you're not familiar with that, we have a lot of really great learnings on the Right Care Initiative website. I encourage you to learn more about it. But after learning about the coronary artery calcium score, I recommended that she do it. And she, after being diagnosed with diabetes, was more motivated and decided to pay out of pocket for it. And no surprise, oh, sorry, I missed a slide. But so she was diagnosed with diabetes, put on a 40 milligram statin and metformin. And so then when she went in to get her coronary artery calcium score, she was at a 403. And so that information was then shared back with her doctor, who was confused as to why it was that she decided to get this score. But after seeing the score, was quite concerned, and so did refer her to cardiology for additional testing and increased her statin to 80 milligrams. So that was early last year, and a combination of the score of 403, the diagnosis of diabetes, and sort of finally getting to that point where she realized I'm really in a pretty serious situation and need to make some lifestyle changes. She has actually implemented some lifestyle changes, and I'm happy to report that as of this month, she's down 61 pounds. Her A1C is down to 5.5, which is technically not even in the prediabetes range anymore. Her HDL, LDL, cholesterol, triglycerides, all looking a lot better than they did a year ago. And all of this is really a lot to do with the fact that she was diagnosed with diabetes and she got that coronary artery calcium score, which put her at a very high risk. And so I'm really happy to see that she's done better, but this woman is really a lot of the inspiration for the work that I've been doing in diabetes. So a little bit more about my background. So prior to working for USC, I was with the American Diabetes Association. In that role, I worked with a lot of diabetes self-management education programs, as well as some national diabetes prevention programs. I managed a team of about 5 community health workers that were doing classes, probably about 2 to 4 classes per community health worker at the American Diabetes Association. Before that, I was with the YMCA of Metropolitan Los Angeles. That's where I really started working with the Dr. Clo's team at the Department of Public Health. And there I was in charge of rolling out the National Diabetes Prevention Program through the YMCA. We had it at about probably, 10 to 15 sites with about 1 to 4 classes per site. So that's my sort of background in working in diabetes and prediabetes specifically. So I just wanted to share some national statistics for prediabetes and diabetes. So you can see for diabetes, we have 3.4 million people in the US. 80 for prediabetes, that number is 88 million adults, so 34.5% of the US population. I have a lot of data to get through, so I'm going to move a little bit quickly through some of these slides. So for this one, prediabetes and diabetes in California by age. In California, more than half of adults, 55%, have either prediabetes or diabetes. This includes 2.5 million adults, or 9% of the state's population, who have diagnosed diabetes. In addition, nearly half of adults, 46%, are estimated to have prediabetes. This represents more than 13 million California adults. And as you can see, both diabetes and prediabetes prevalence increases with age. So here I have some prediabetes data by county and by age. So the prevalence of prediabetes varies county to county among California adults. And because age is particularly a strong risk factor for diabetes and prediabetes, this figure shows estimates of county-level prediabetes prevalence broken out by age group. And I think this regional variation is likely due to a couple of different factors, including differences in demographic, social, economic, and environmental factors. So these are a couple of different Southern California counties, but I know we have several Northern California folks on the line as well, so I figured I would include a little bit of data for those of you who are coming from the Northern California counties. So I want to say a quick word about prediabetes awareness. So this figure you can see shows percentage of the US adults. Oh, not sure what happened there. Okay, percentage of US adults who have ever been told by a healthcare professional that they have prediabetes. So the percentage, so though the percentage of adults with prediabetes in California is estimated about 46%, the percentage of those who have been given this diagnosis is about 8%. So that's a huge gap in awareness. And if you think back to my mom, I don't think that should be too surprising that we have such a lack of awareness of folks who actually have prediabetes. So just to drill down a little bit farther into Los Angeles, I'm trying to get to the next slide. Megan, I'm not sure if you have control or not, but I can't seem to get to the next slide. There we go. Okay, so here's Los Angeles County. I'm sure those of us on the line from LA are quite familiar with this image, but this is LA County broken out into spas. LA County is a massive county. You can see there on the right that if we were a state, we'd be the 9th largest state with a population over 10 million. And so we divide our county into smaller little service planning areas. And so you can see on the map that we have, 8 different service planning areas? Yes. So spas 2 and 5 generally have the best health outcomes, whereas spas 1 and 6 generally see the worst health outcomes. And so you can see here some health outcomes on diabetes, overweight, and obesity, and cardiovascular disease. For the diabetes, percent of adults ever diagnosed with diabetes, as I mentioned, you can see SPA 1 and SPA 6. So way out there in Antelope Valley, Lancaster, Palmdale, those have the worst outcomes. And then in South LA as well, we have the worst outcomes. And then some of the best outcomes we have are in the San Fernando Valley and West LA. So those are a lot of those beach cities, and then some of those more wealthy areas in the San Fernando Valleys in SPA 2. So diabetes-related complications can be serious, costly, and deadly. They include things like heart disease, stroke, kidney damage, chronic kidney disease, and kidney failure, blindness, amputations, and diabetes-related complications are more likely and more severe among people whose diabetes is not well managed and those who have had it for longer. So when we think back to how age plays into this, it's important to remember. So people with diabetes can better manage their condition, improve their health by following preventive care practices. These practices include annual foot exams, eye exams, and attending diabetes self-management classes. And as you can see here, the only recommended practice that has consistently met or exceeded the Healthy People 2020 target was the dilated eye exam. In 2015, the goal of having 2 or more A1C tests in the last year was also met, but the all-state median percentage for ever attending a diabetes self-management class was the lowest among all of the preventative care practices. And these programs can increase the use of all of the other preventive care services, helping to improve quality of life for people with diabetes and reduce healthcare costs by lowering the risk of complications. So there are barriers such as not having insurance coverage and living in rural areas that can make it hard for people to participate in this program. So again, you think back to SPA 1 all the way out in Palmdale, Lancaster. A lot of those communities don't have the access that would allow them to have hopefully better outcomes. Okay, so moving to, thank you. So with that said, in California, we're doing better with DSME participation. And this table shows estimates of the percentage of U.S. adults over 18 who have been diagnosed with diabetes who reported receiving some preventative care practices by state. So this data is from 2015, but for the data shown in California, we are missing the mark for all except for DSME class attendance and the dilated eye exam in the last year. And you'll notice we are doing incredibly poorly in the daily self-monitoring of blood glucose. So there is I have a little bit of data to share. So next slide. I'm not sure if you're still, if you're controlling it or not, Megan, but. Okay, so for the programs that we have in LA County, we have right now about 32 different organizations with 32 sites, which sounds like a lot, but again, when you have a county the size of LA, sometimes that just doesn't provide enough coverage for some of those farther communities like Lancaster and Palmdale. Next slide. So just a quick word on, I know I'm running out of time, on the cost of diabetes. So I have listed the direct costs in terms of medical costs but also the indirect costs. So that would include things like absenteeism, presenteeism, household productivity, inability to work, and premature mortality. Next slide. And so here's a little bit of data on the number of NDPP programs we have in LA County. So just some background here. So in 2014 was when the CDC awarded the 1422 grant to 17 states and 4 cities, which included California, LA, and San Diego, to help increase the access to these programs. And so you'll see that there's quite a rapid increase of available programs, and then a pretty significant decrease there from the 2016-17 grant year to then skipping to 18-19. We don't have data between 17 from the 17 to 18 grant year because that was sort of that time period in between the 1422 grant and the 18-17 grant. So the reason why that we see this grant is, or this drop is not just because of the lack of funding, but because the programs that we're able to get up and running thanks to the 1422 grant, and we're able to get reimbursement for those programs, the reimbursement isn't quite at a place yet where programs are able to easily sustain their program with just reimbursement funding. Next slide. Okay, so I just wanted to share a couple of quick things before I wrap it up. So this is a toolkit that was developed by the CDC to help employers, insurers, and providers and state health departments estimate the health and economic effects of offering the DPP to populations at risk of developing type 2. A great resource. Next slide. So with this, you're actually able to input, I know it's a little bit of a cramped image to fit on one slide, but you're able to actually input details about your specific constituency and get tailored estimates of the health and economic effects of offering the National Diabetes Prevention Program to populations at risk. Next slide. And we also have another coverage toolkit that was developed to provide information about the mechanics of covering the program with a lot of great resources online. Next slide. So I do have a poll real quick that I want to launch just to get a sense of what kinds of involvement you guys have with some of these programs, if you're providing them or if you're referring out to them. And so if you can launch that poll, great, thank you. Can everybody see the poll okay?
Yes, it's on the screen.
Okay, great. There we go, starting to get some responses in. Let's try to wait until we at least get to about like 30%. We have a couple more minutes. If you guys can take a couple of minutes to check out the poll, it should be on your screen. And you can select as many things or as relevant to your particular organization. Wait until we get to 2 minutes, Megan, before we publish. See if we can get to more. There are a lot of things to read through, and I recognize that. We'll give you guys a little bit more time to read through all of the different options. A couple more seconds, and then we'll close the poll. So hurry up and get your responses in. Okay, great. And then can you share the results? Perfect. All right, so looks like a good number of you run a diabetes prevention program. A little bit more of you have experience running diabetes self-management programs. Makes me happy to see that there aren't many people that aren't doing anything with it, but hopefully these next two presentations that we have for you will help you learn a little bit more about the programs and see if it's something that might be a good fit for your organization. And great to see we have such a strong representation out there from Los Angeles, but a lot of other folks from different areas as well. So with that, I'm right at time, so I'll turn it back over to Carol.
Thank you, Alissa, very much. That was really interesting, and I have to say I'm impressed that your mother really reduced her hemoglobin A1C quite dramatically. Good for her. The other point that I'll bring about, also, if anybody on we have 90 participants now. If you have any questions, please enter those into the chat box, and if we don't get to them at the end of the discussion, we'll have time for the group discussion later. But I think the fact that we have almost 50%, according to your statistics, of pre-diabetes, which is under the tip of the iceberg, and diabetes is incredible. So we clearly have work to do, and hopefully our next two speakers will address that. So I'd like to introduce our next speaker, Dr. Bernadette Mejia. I hope I pronounced your name correctly, Dr. Mejia. And
you did, thank you.
Thank you. Okay. She's the Director of Preventive Health Services at Watts Healthcare, and she's going to talk about the National Diabetes Prevention Program and diabetes self-management. So thank you very much, and take it away.
All right, thank you everybody for joining us today. So today I'm going to talk about Watts Healthcare Center's dual services that we provide. So we do provide the diabetes self-management education program and the diabetes prevention program over at our location. Next slide, please. So for my presentation, I did want to do a brief overview of what I will be talking about. So I will talk about a little bit about Watts Healthcare Corporation, why we implemented the diabetes self-management education and diabetes prevention program over at our center. I'll also review standards of the American Diabetes Association recognized DSME services because the classes that we're offering, the curriculum, we are recognized by the ADA. I'll also talk about the elements of the CDC preliminary partial full recognition for the DPP program. And also, I think a lot of people might want to know how did we implement dual services at DSME and DPP? Basically, what works for us, what has been working for us. And then I will also present some data on the ADA DSME services, pre and post A1C of the patients that have been attending our classes. And also I will be presenting data on the DPP services that we've been providing. So basically the weight loss trends that we have been observing. And also I think it will be helpful to go over barriers and enablers of implementing these dual services. Next slide. So about Watts Healthcare Corporation, we are a federally qualified health center. So I think one of the things that I do want to stress out is, I'm very familiar with the reimbursement rates with an FQHC setting, not so much if it's like in a hospital setting or anything like that. So if anybody is from an FQHC, then this will be really beneficial for you. We also do we have multiple services and departments within Watts Healthcare. So we have an adult medicine department, we have a pediatric department, OBGYN, radiology, WIC sites, on-site, and then we have 4 other locations off-site. We have a health education department, maternal and child health, tobacco control, dental department, and vision. So we do have a full range of services that we offer to our patients. We do about 30,000 encounters a year. Most of the patients that we see have multiple complex chronic diseases. So like, for example, We'll see patients with type 2 diabetes, hypertension, and CKD, just to so you guys can see what type of population we're serving. We're also located in Wops, California, and Alissa did briefly mention the different service planning areas. So actually, we are located in Service Planning Area 6, which I will go over in a little bit. And we have been in the community for over 50 years. So we've been around for a while. Next slide, please. So why did we decide to implement dual services? Alissa basically shared some of like the national averages of patients with diabetes and prediabetes. So just to reiterate, 30 million people in the US have diabetes. 1 out of 4 don't know they have it, according to the CDC. 84 million people in the US have prediabetes. 90% do not know they have it. And scientific evidence shows that DSME classes show an average reduction of A1C of about 0.8% in patients with A1C greater than 9%. And I also did want to share that evidence does show patients are able to reduce their A1C up to 2% if they see an RD as well, which is a registered dietitian. Scientific evidence on DPP classes show participants achieve weight loss of 5 to 7% of their body weight, and also reduce the risk of developing type 2 diabetes by 58% in adults. So all of this is actually like on the ADA website or the CDC website. Specifically with Wops Healthcare, if I queried data for those patients that are 18 plus years old, there's about 2,283 patients with type 2 diabetes within the past year. And there are 364 patients with pre-diabetes in the past year. So I just wanted to show you guys a figure on the type of demographics that we're seeing over at Wops Health Center. And then I think that was great what Alissa was sharing earlier, that since Wops Healthcare is in SPA 6, the percentage of adults in SPA 6 is the second highest. So you can definitely see there is a need within the community to implement these dual services. And then I think what also was really fascinating is that SPA 6 has the highest death of diabetes rate among SPA 6. So there's definitely a need within Wops Healthcare and SPA 6 community to attend these classes. And, you know, a lot of our patients over at our center, it's almost like a family atmosphere. So I was receiving a lot of feedback, my team and I were receiving a lot of feedback that they were interested in a weight loss program. So because of that interest in a weight loss program, I was able to look into the DPP program and how one of their health outcomes was to help patients lose weight. So that was what really pulled me into finding out more about this DPP program. Next slide, please. So I really just want to do like a brief overview of the elements of the ADA recognition for the Diabetes Self-Management Education Program. And I can't stress enough to check out the ADA website so that you can find out more detailed information on each of these elements. But briefly, so they want to make sure that there's an internal structure. So they want to make sure that that the corporation has a defined and has a documented mission statement and goals. They want to see an organizational chart, and number 2, stakeholder input. So they want to seek input from stakeholders and experts to promote quality and enhance participant utilization. So with that, every year during our 4-year certification period, I'm holding meetings that involve primary care providers within our facility, patients that attend the classes, team members that actually provide the curriculum. And so we basically get their input and see how we can enhance the class, how can we increase patients to come into the class and things like that. I also share with the stakeholders, the data, like our CQI data, which I'll be presenting later on. Also, they want to see an evaluation of the population served. So, they want to see demographics, they want to see the evaluation of the community we serve. So that would be great to show things like, for example, what Alissa shared with the SPOSTIX data and things like that. Number 4, quality coordinator overseeing DSMEC services. So they just want to make sure that there is somebody that is overseeing and making sure that all the QI and the tracking and implementation of the classes are being implemented appropriately and are following the standards to maintain this ADA recognition. So the quality coordinator can be someone that has 15 CEUs in relation to diabetes, okay? The DSMES team, so they want to see at least one of the team members responsible for facilitating the DSMES services is either a registered nurse, a registered dietitian nutritionist, or a pharmacist or healthcare professional holding a CDE or BCADM. So basically a CDE is a certified diabetes educator. And then also other team members of this DSMES team are considered paraprofessionals. So any of these paraprofessionals have to have their 15 CEUs in relation to diabetes care management, and they don't really need any other credentials. They're just considered paraprofessionals, basically. They just have to have the 15 CEUs. So what I do over at Wops Healthcare is that anybody that coming into the class to facilitate, co-facilitate, or even translate the class to another language, for example, Spanish, that they're maintaining their CEUs on a yearly basis. Next slide. So another item they want to see is the curriculum. The curriculum has to be recognized by the AADE and the ADA, and it has to reflect current evidence and practice guidelines. So right now, the curriculum we're using is the conversation maps, and it's by Journey for Control. So that's the curriculum we're using. It's a four series class. So with that being said, within the month we hold each class on a weekly basis, every Wednesday, for example, and we just repeat that cycle throughout the year. So some of those topics include Basics of 101. Another topic includes healthy eating with diabetes. Another topic includes monitoring and managing your diabetes. So those are the different topics that the curriculum we use entails. Another great thing about, in order to be ADA recognized, is they want to make sure there's individualization. So DSMES needs will have to be identified and led by the participant with assessment and support by a DSMES team member. So what we do specifically at Wops Healthcare is once we see these people are entering the class and participating, we also like to schedule them to see the RD. And so the registered dietitian will basically work one-on-one on this individualization plan. And so there's several forms that they complete with the patient. So they do a questionnaire, how long have you been diagnosed with type 2 diabetes for? What's your support system like? What are you eating, your dietary intake? How do you feel? Are you feeling depressed? Things like that. And then we also have another DSMES form, which goes over basically the pre-assessment, like the patient's knowledge of diabetes, and then a post-assessment of their diabetes knowledge after they've completed the 4 sessions of the classes. And then we also have a goal form, a DSMES goal form. So the patient, we kind of help and facilitate, guide the patient to come up with a goal in relation to their diabetes, whether it be, hey, I want to incorporate more vegetables that are low starches, right? So that's just an example. And then we try to say, okay, how often do you want to do that? 3 times a week, every day, all 3 meals. So that's just an example. And then ongoing support, number 8, participant is made aware of options and resources available. So basically, that's another DSMES form that we complete in our electronic health record system. And we basically, it's just basically a checklist, like, okay, they're made aware of the resources around the center, the community, like YMCA, things like that, so that they know that there's other places that they can go to exercise or get recipes and things like that, like other LA Care family resource centers. Participant progress. So the provider of DSMES will monitor and communicate whether participants are achieving their goals and other outcomes. So we basically have this whole tracking system which tracks whether, and I know there's multiple tracking systems out there, like, but what we do internally in-house. And so we basically keep track of all the patients that enter the class. We keep track of whether they've seen the initial visit with the RD, post-visit with the RD. We also keep tabs on their pre- and post-test scores after they complete the series of the classes. We also keep track of their A1C before they enter the class and after they completed the 4 class sessions. So those are things that we're looking at and tracking for each of the patient. And obviously, all of this data is presented to the ADA. We present this data. I also present this data during our quality management meetings, director meetings, stakeholder meetings. And the patients know as well their progress too. Quality improvement. So I'll go over that in the next couple of slides. So next slide. Okay, so now elements of the CDC Prevent Type 2 Diabetes program. So once again, I cannot stress enough, going onto the CDC website, just Google CDC Prevent T2 program, and it shows like the DPRP standards. That'll be very helpful. I mean, I had to read it multiple times to really understand the content of what the program was asking for and things like that. So participant eligibility in terms of patients, okay? So patients that are reportable data to the CDC is they have to be 18 plus, they have to be overweight, okay? And they have to have a recent blood test of indicating that they have prediabetes. And there's other factors too, like if you had a history of gestational diabetes, that's another thing. If you're Asian, I believe the BMI is 23 and up. And then also, so it's just really important to read the standards because this is the very general participant eligibility. When I first signed up to do the DPP program at Wops Healthcare, I received a call from the CDC, and they just wanted to basically know, like, where's this location? What's your delivery mode? Is your delivery mode going to be in-person, online, distance learning, or a combination? So our delivery mode is in-person, and we do also hold makeup sessions. So you're actually allowed to hold makeup sessions within the week before the next session. So that's what we did. Just in case somebody couldn't make it on the Fridays, we would hold it on a Tuesday. Staffing. So the facilitators of the class have to be certified lifestyle coaches, and that's something that when the CDC like interviews you to do the DPP program, they want you to ensure, where are you going to get these people trained on the curriculum and how to be certified lifestyle coaches. And you also have to have a designated program coordinator. So basically, the CDC website, it shows basically a list of places or entities that could certify your staff to be lifestyle coaches and to teach the training of the curriculum. So the prices vary. I saw ranges from like $240 to $400 per person. And then the delivery mode of those trainings were either entity could send a person to your location, or they do online courses once a week for a span of, I don't know, 4 to 5 weeks or something like that. So it really just depends on the timing of your staff and what, what's within your budget. And then also number 6, required curriculum content. So there's a variety of curriculum topics that the CDC wants you to go over from months 1 through 6, because it is a year-long weight loss prevent T2 program. And then there's a particular amount of topics, certain topics that they want you to review within months 7 through 12. So what you'll find is that you might be, during those months 1 through 6 and months 7 through 12, you could be repeating some classes of the same content, and that's okay, that's allowable. Next slide. Okay, so the DPP offers pending preliminary and full recognition. Once again, these are all items you can go, and I put the link there so you can see the DPRP standards. Pending recognition is what they initially give you once they say, okay, you met the criteria to start facilitating the classes, and they grant you pending recognition. And so over time, you could be either given preliminary recognition or full recognition. And so preliminary recognition is if the organization has met requirements. A pending recognition has at least 5 eligible participants who attended at least 3 sessions in the first 6 months, and whose first session and last session of the program was at least 9 months, and among participants meeting criteria in number 2, and at least 60% attended at least 9 sessions in months 1 through 6, and at least 60% attended at least 3 sessions in months 7 through 12. So this is why it's so important to read the standards, because it's almost like you have to read it over and over and over again to really understand what is entailed in receiving preliminary recognition and full recognition. And then full recognition entails all of number 2 is being met, but then the eligible participants that you're able to report to the CDC have an average, at least 4 patients have to have an average body weight loss of 5%. So these are just the requirements to receive either pending, preliminary, and full recognition. Next slide, please. Okay. Tools and tips to implement dual services. So I think this is like one of the biggest questions I received from peers who are interested in implementing dual services in their facility. They want to know about staffing. They want to know about the frequency of the classes, and so forth. So for the location over at Wops Healthcare, to apply the DPP and DSME, there's myself as the project director. I have a health educator coordinator who's also known as the paraprofessional, who can help co-facilitate the class. I have one health educator and a medical assistant that basically helps translate the class, helps process referrals that are received from the provider to schedule these patients for the classes, and any other help with CQI. And we also, actually, I didn't put it in there, but we have an RD that's the lead facilitator. So I'm an RD, but I also have another RD that helps facilitate the class as well. The frequency of classes, so what works for us, I've heard other locations, they do the class 1 time a month. But over at Wops Healthcare, we do it every week. So as long as it's a working business day, every Wednesday, we hold the classes. And so we have a Spanish class in the morning, so just solely Spanish class, and then we have an English class right after, like around 10:30 a.m. And then we also just implemented a afternoon class on Wednesday as well, which is a bilingual speaking class, just so that we can really try to, we added another class just to have the availability there for working patients. Internal data tracking system. So like I said earlier, we have an internal tracking system where we track all this data, A1C, their pre and post test scores, whether they've seen the RD, whether they had a follow-up with the RD. And so it's really required just to do this on a quarterly basis, but we do it every week. We just like to make sure everything is aligned, that we're keeping tab on all those patients. It's really helpful because sometimes, we can look at our electronic health record system and see, oh, hey, there's an updated post A1C score. Let's add that so we can see, whether they've improved their A1C, right? Let's see, number 4, implementation of DSME forms on electronic health record systems. So to be recognized, they want to have these DSME forms completed. And once again, these are all forms that the ADA share. They share it with us, what kind of forms, the ERP, they share these forms that they would like for you to complete on an individual basis with these patients. So they hold a lot of webinars and trainings on this. So it's a very accessible form. We just put it in our electronic health record system so that everything's, easier to find and to check up on later. And then we also have an internal referral process. So the doctors over at Adult Medicine, same day, throughout the facility, they're very much aware that, there's an ADA recognized program, diabetes program, and DPP program with it on site. So, we receive a lot of referrals every day for their patients to come join these classes. And, we even include patients that have type 2 diabetes in these DPP classes as well, because it is pretty beneficial. Next slide. So a big thing that we did is we market these classes. So we have flyers. We send out emails to all staff. We do have social media. So we have various social media outlets like Facebook, Instagram, Twitter, which we market the classes. And I think a big thing that helps us in bringing in new patients are texting campaigns that we provide. So there's the initial texting campaign saying, hey, we have this classes that we're now offering. And then I also do monthly texting campaigns. So for example, if a patient saw their PCP provider in February and they have the diagnosis of diabetes or prediabetes, we're sending out texting campaigns to those patients to come join these classes so it's fresh, because we know that they just spoke to their provider about their A1C, so we want to invite them to come to join in the classes the following month or sooner. Utilization of interns and LVN students. So, over at our facility, we have a lot of interns and LVN students that come in and so I take advantage of that. Have them make reminder calls to call these patients to come in, or if the texting campaigns don't work, then they can call these patients as well. Sometimes patients like to hear the voice of somebody, and then we schedule them from there onto the system. Scheduling patients in EHR to receive reminder calls. So that's another way that we ensure the patients come to the class. It just helps that they get the reminder call when we schedule them in EHR so that they can just say, oh yeah, I have a class tomorrow that I have to attend to. So I just feel like it does help boost participation. And then makeup sessions allowable within the week. That's for the DPP program. Reimbursement rates. So for an FQHC setting, the RD that teaches the classes, they have an NPI, so it's a billable encounter. So in a given month, like for example, at Wops Healthcare, we can generate up to 190 billable encounters from both classes. and that doesn't include the RDN pre and post visits for the individualization of the DSMES. So that's something great that if you want to start these programs, you can mention this to, you know, the CMO or the CFO and say, hey, you know, I think the ROI on this is very good if we hire these type of people. And then once again, I cannot reiterate enough, read through the standards of the DSME and DPP programs, because they offer a lot of webinars, a lot of trainings. They're always sending out emails saying, come join this webinar. They're readily available over the phone too. You can just schedule an appointment. Next slide. Okay, so I just really briefly, before my time is up, I just wanted to share like our ADA DSME services, the results for the ADA classes that we hold. So I'm just going to go over year by year of our certification period. So our cert period is, our active cert period is from 2017 through 2021. So the CQI goal that we have, that we review is by completion of the series, which is they complete the 4 classes, 50% of our patients will have decreased their hemoglobin A1C by at least 0.5%. So from October 2017 through September 2018, within that year, we had 27 patients who completed the series, okay? And of those, 55.5% reduced their hemoglobin A1C by at least 0.5%. So our goal was met for that year. But overall, if there was any reduction in hemoglobin A1C by 0.1% or more, 22 out of 27 patients reduced their A1C. Next slide.
You know, what the separation is through metal, so, you know.
Okay, so for the second year, there were 44 patients who have completed the series, and in which we have pre and post hemoglobin A1C lab results available. So 31 patients out of the 44 reduced their A1C by at least 0.5%. And then overall, for any reduction, 0.1% or more, 35 out of 44. Next slide. So the most up-to-date data that I have for October 2019 onward, let's see. So there are 16 patients who have completed the series thus far, and of the 16, there were 8 that have completed reduced their A1C by at least 0.5% or more, so that's 50%. And then also 14 out of 16 patients have reduced their hemoglobin A1C by 0.1% or more, 88%. So basically, since, you know, this is relatively new data, it's changing every week because, you know, over time, as weeks progress during the cert year period, we're getting A1C data, post A1C data, so that our number of patients that have completed the series and those who have reduced their A1C, that number may increase, okay? Next slide. So internal results from the CDC DPP services offered. So we've already submitted our first 6 months of data, and then our first submission, we already did our first submission, and our second submission is due actually this month. So I was able to pull some data on that. So basically, our organization approved date was 2/7/2019, and our effective date was 3/1/2019. So our first submission for 2/7/19 through 8/31/2019, we had 21 participants, eligible participants who were overweight or obese, and they had the diagnosis of prediabetes. So these are 21 participants with that that met the criteria to report to the CDC, but obviously we probably had about 100 patients plus join the classes. Next slide. Okay, so this table basically just shows the weight change reported at the first submission. So you can see the ones that are highlighted, bolded, and in blue. those are the patients that lost weight. So this is from the first submission. So patients 1 through 21, you can see that there's like the 2.6 pound weight loss, 5.2 pounds, 1.4. So I'm looking all the way to the right column. Patient 10 lost 7.2 pounds. Patient 11 lost 4.2 pounds. Next slide. And then here's similar. Patient 14 lost 9.6 pounds. Patient 17 lost 6.6. And then patient 20 lost 7 pounds. And patient 21, she's the one that's been losing the most weight. She lost 17.8 pounds within that time frame. Next slide. So summary from table 1, so 13 out of the 21 eligible patients lost weight, so that's 62%. So there was a weight loss range of 1.4 to 17.8 pounds, average of 5.6 or 2.34% weight loss. Next slide. Okay, so the second submission was for data for 9/1/2019 through 2/29/2020. So out of the, I'm sorry, it says 23, but it's 21. So out of the 21 that were identified, 10 of those continued on the series. Next slide. So now I'm sharing those 10 patients. Weight change reported at second submission. So once again, everyone highlighted in bolded and in blue are the ones that continue to lose weight. So patient number 2, 10, 18, 19, and 21, this is the weight loss that they had within the second submission, within that time frame. So once again, patient 18, 5.2 pounds were lost during that time period, and patient 21, 8.6 pounds lost. Okay, so next slide. So 5 out of the 10 eligible patients lost weight during our second submission. Range of 1.6 to 8.6 pounds were lost, a mean of 4.32 pounds or 1.88% weight loss. Next slide. So now I just wanted to show the weight change from the initial class they participated in and the last date of the class they've done so far. Because we're still ongoing, it's not done yet. The year-long weight loss program isn't done yet. So once again, those highlighted in blue are the patients that lost weight. So 6 out of the 10 lost weight. So range of 4 to 27 pounds. So the most that the patient has lost since we started the program is 27 pounds. Patient number 10, 17 pounds. So one of the components for full recognition is that the average weight loss among all eligible participants should be a minimum of 5%. Right now we're at 4.6%. So what I would like to do with these identified patients is probably schedule them for a one-on-one session with the RDs. Okay, next slide. Okay, so next up, barriers and enablers. So things to think about. Staffing. Do you have a project director in mind, or would you have to hire somebody? Is there funds for this that you might have? It also might help to do like a ROI report to the CFO or anybody in the C-suite saying like, hey, you know, the reimbursement rate or the PPS rate. As far as I know, in the FQHC setting, you know, there's you know, you can really get a reimbursement from that. So that's something you might want to present. Frequency of marketing campaigns. So, you know, it has to be ongoing. I think that's what brings and generates new patients to the class. Collaborative effort from other departments. So, you know, really, so marketing campaign not only towards the patients, but also to the other departments that are within your facility. Like for us, you know, adult medicine, IT, administration. Another thing to think about is the cost of the training. Like I said earlier, for example, for the DPP, each person to get them to be certified lifestyle coaches could range from $250 to $400, and that may not include traveling, tracking systems. So what will work for you? So we have an internal process, but I know there's other tracking systems that are available. So finding out what will work for you. Pros of the Doula services is, obviously, as you saw, in SPA 6, where Wops Healthcare is located, there's definitely the need, right? So, we're seeing results. We're getting improved values under hemoglobin A1C. We're seeing some patients are losing weight, so that's really great. And then obviously, if you have prediabetes and you're losing weight, then you're reducing your risk of type 2 diabetes. Family support system. So, a lot of times the people in the classes, they love the classes. The patients love the classes. And they also build almost like a support system with their other classmates that are in the class. So we hear stories that, patient A, B, and C, they all went to the gym or they all went walking around the neighborhood together. So that's always great to hear. And then we also hear qualitative results from the patients saying that they've increased their physical activity, they've improved their mood. And then lastly, I think what's important for health centers or FQHCs in general to know is that you're able to generate billable encounters if you have the right staff on board, like somebody with an NPI number. Next slide. And that's it. So I just left my email address and personal email address. So if you guys have any questions, you can just shoot me an email. Thank you.
Megan, are you able to unmute Dr. Zaher?
Yeah, here I am.
Okay, there she is. All right.
All right. Thank you very much. I really appreciate that, that discussion. I do have one question from the audience right now, and any other members of the audience, feel free to enter a question in the chat box, and we could do now or again at the group meeting. But there was a question now, are there any plans to provide diabetes self-management classes via an online platform for patients that live in very remote rural areas? Do you know anything about that with the program?
You know what? I know there's more so online. I've received an email like you can do online DSME, but I know definitely that there's online DPP that is provided.
Okay, and of course that always gets into the issue of the accessibility of, remote access with internet, et cetera, et cetera.
Mm-hmm. Right. And then something to consider too is I don't know if that person's facility is like a trailblazer with telehealth. So that's another thing to consider as well.
Right. A question I have, it seems like years ago now, and they passed by quickly, we all know, there was an element of using promotores, that type of educational benefit in communities, and it has changed names over the years too. Do you use anything like that in the model, or what's your comment on how that has progressed over the years as a possibility?
So promotores are, from what I know, is they kind of do outreach, right? So the form of that we do it is that, the marketing, the texting campaigns instead, and then obviously word of mouth within the clinic and informing the providers about the classes. But the staff that I have, 2 of them are bilingual, so they're able to kind of talk to the patients and get them involved in the class and talk to them once we get the referrals from the providers. And then instead of promotores, I'm using also the LVN students that come in. So that's kind of I mean, promontories, they're like paid staff, I'm assuming. When these interns come in, it's, they're volunteering. So that's something to think about.
Right, right. Okay, we're just about, this perfect timing. We're about at our next topic. And again, send your questions in for the group discussion later. But Dr. Mejia, thank you very much. And we'll chat with you in the group later.
Thank you.
I would like to introduce now Christopher Tompkins, who's a health promotion manager from Anthem. And he's going to talk a little bit about the payer perspective and how, what types of activities payers can get involved in to move our goals to fruition. Christopher, are you there?
Yes, I am. Can you hear me?
We can. Thank you.
Perfect. Well, thank you for having me today. Just for the group, I'll give a little background on myself. My name is Chris Tompkins. I'm a health promotion manager for Anthem Blue Cross here in California. My primary responsibility is to work with our strategic accounts, so with our clients, to implement evidence-based programs to help impact healthcare costs associated with their Anthem members. So part of the evidence-based programs that I am the business lead on here for Anthem is the diabetes prevention program. Now keep in mind, Anthem does have 14 states throughout the United States where Anthem plans are currently in place. California kind of does their diabetes prevention program a little bit different than other states. So I will specifically be speaking about California and the way we do it here. If you do have additional questions, please feel free to reach out to me and I may be able to answer them for you at a later time. But that being said, let me see if I can advance the slide. Oh, there we go. It was delayed a little bit. So we're here to talk about the diabetes prevention program that Anthem Blue Cross included as a preventative benefit to Anthem members. So the reason Anthem primarily went down this road was due to the USPSTF, so the United States Preventive Task Force, gave intensive behavioral counseling for cardiovascular risk reduction a grade B rating. Hold on one second, let me go back. The slide was jumping on me. It gave them a grade B rating, which essentially means that Anthem chose to add it as a covered preventative benefit for Anthem members. Seems the screen's jumping around on me a little bit. In 2016, on actually January 1st of 2016, Anthem added it as a preventative benefit to all of our commercial plans. And when I say commercial plans, this is excluding Medicare. As we know, there is a Medicare DPP program. And also some plans that are able to pick and choose what they want their preventative benefits to be, or if there is a grandfathered plan that doesn't have to follow the ACA guidelines. So there are some considerations as far as groups that are eligible or Anthem members that are eligible for the diabetes prevention program. But above and beyond, the majority, I would say 99% of Anthem members have the diabetes prevention program as a covered preventative benefit in part of their plan. So one of the main reasons why Anthem did this is because we're seeing a staggering amount of cases increasing around diabetes. So Anthem's deciding, what do we need to do, or what can we do for our clients to help reduce the prevalence of diabetes among our Anthem members associated with these groups. So they implemented the diabetes prevention program. Let me see if I can advance the slide one more time. And it seems I'm having difficulty advancing. Oh, there we go. There's just a delay. There we go. So Anthem looked at the statistics that CDC provides us. So as we know, 1 in 3 of us is at risk for diabetes. In California, that's actually a little bit higher, significantly higher than 33%. That means more than 84 million Americans today have prediabetes. And if you're not sure or aware of what prediabetes is, essentially it's having blood glucose levels higher than normal, but not high enough yet to be actually determined as a diabetic. The one interesting statistic, and I talked with CDC and CMS regarding this, is of those individuals that are at high risk for prediabetes, if nothing is done about those prediabetes within 3 years, 15 to 30% of them will develop type 2 diabetes. So Anthem looked at this data and they figured, you know what, let's implement this diabetes prevention program. We'll try and put it in here. And we were one of the first states to implement it without looking at a cost analysis around it. Meaning we looked at the CDC data, but we didn't build it into the plans when providing it to Anthem members. Other states have looked at that. Other health plans across California have looked at that. But this is one thing Anthem didn't do because one, we have to take into consideration, you know, do we have fully insured clients? Do we have self-insured clients? How is this going to look across the board? And we wanted to make sure it was the same platform for everyone. So two of the key factors why Anthem did this and why something that we definitely introduce and speak to our clients is some of the research that's been done around the diabetes prevention program. One of the details, and this is data that's been done across the United States, it's not specific to California, is if you look at the average health plan costs associated to a diabetic member and a non-diabetic member, you can see that there's a 2.3% or times increase when you have an individual that is a diabetic member versus a non-diabetic member. So it's in our client's best interest and also Anthem's best interest to try and keep individuals healthy and prevent them from becoming a diabetic because we see that increase in healthcare costs associated with those diabetic members. Another study that was done by CMS, so Center for Medicare and Medicaid Services, cited a savings of $2,650 per DPP participant who attended the first 4 sessions of the DPP program. Please keep in mind that the Center or CMS, they did this data around our Medicare population. So this is not a commercial plan that we're essentially looking at. There have been some more recent studies done in Florida from a commercial plan where they've gone through and analyzed the data, and Anthem is currently analyzing some of the data across all 14 states right now regarding diabetes prevention program, but I don't have it to share at this time. So this is kind of what you get as far as everything that is out there so far. So there are many multiple factors contributing to high risk for prediabetes. You have weight, age, family history, ethnicity, activity level. Blood sugar is a key element that we're analyzing to find out if there is an individual at risk and not at risk, but we also look at individuals when they complete a questionnaire, which identifies some of these multiple factors associated with them. The most recent quiz that CDC released around it also considers or looks at hypertension as one of these risk factors as well for prediabetes. So the good news that we share with a lot of our clients is, yes, there is a lot of high cost claims around diabetes. And one of the more current or longitudinal studies that was done was in 2001, was the National Institute of Health and the Centers for Disease Control and Prevention proved that losing just 5 to 7% of body weight via dietary changes and increased physical activity resulted in a 58% risk reduction of developing type 2 diabetes. So we really try to promote the diabetes prevention program with our clients, saying we're trying to increase physical activity and good dietary habits through behavioral change, which can demonstrate long-term benefits if these individuals continue to implement these behavioral changes. Try to advance the slide again, hold on. So what is the diabetes prevention program in itself? Well, there's many different organizations that offer the diabetes prevention program, and I think that's one great benefit because one program doesn't meet the needs of every single individual. And when we were looking for a vendor to offer the diabetes prevention program here in California, we had to consider, one, California's very diverse population, and two, the various time restrictions that individuals have to participate in the diabetes prevention program. So we wanted flexibility in looking for a vendor to offer these programs. So the diabetes prevention program was developed by the CDC, which I'm sure you're aware of, and it is structured around a 12-month program. The first 16 weeks of the program are allocated to meeting one time a week for those 16 weeks, and then it shifts into meeting one time a month for the remainder of the 12 months. The class includes personal health coaching, weekly lessons, small group for support, and the vendor that we chose actually offers an incentive tool for individuals that enroll within the diabetes prevention program. So we looked for two platforms. One platform is being a digital platform, because we do know that as far as flexibility, that's an important factor to our Anthem California members. And we also looked for the capability of offering in-person classes, which has been shown to be a little more effective in individuals reaching that 5% or 5 to 7% of weight loss, which is that 58% risk reduction we're really looking for. So on the digital platform, individuals that sign up for it, they are sent a wireless scale, and it's included within all the costs. There's no additional cost to the member. It's within the claims costs that come into Anthem and either paid by the plan or paid by the fully or self-insured client. For all individuals that enroll within the program, when they meet that 4-week criteria, which again was that $2,650 cost savings that CMS showed, a activity tracker or a Fitbit is also, they're eligible to receive it. As far as a link is sent to them, they click on the link and they can pick and choose which Fitbit they want, one of 2 of them, or if they want to upgrade to a different one, they can keep those credits for the Fitbit and then just pay the difference. So there are incentives built into the program, which we get a lot of employer groups that say, well, how do I promote it? How do I get a lot of attention drawn to the program? And really we see members saying, oh, it's a free Fitbit. I have to complete the first 4 weeks of the program. And that's where we're really trying to push, because once they get to those first 4 weeks, we see a lot greater participation in the program, or longer activity in the program when they do reach those first 4 weeks. So there's a lot of great initiatives tied into the program. And again, it's at no additional cost to the members. I'll advance the slide again. There we go. So to support a little bit of the evidence around it, the study that was published within the New England Journal of Medicine in 2002 looked at the placebo, the Metaform, and diabetes prevention program, and showed that 58% risk reduction. So there is research to support the diabetes prevention program and the impact it has on individuals. This is a little more interesting as far as being able to share this with clients, because a lot of clients say, well, are all individuals that enroll within the diabetes prevention program going to reach that 5% weight loss or more? And to be honest, yes, that's the goal of the program, for that 58% risk reduction, but we see a risk reduction for individuals that lose just 1 to 2 to 3 to 4% of their body weight, as far as reaching that goal over a longer period of time. So we really implement that, look, yes, this is a behavioral program for individuals to participate in. If they don't reach that 5% weight loss, maybe they reach that 3% weight loss, which still reduce the chance of them, developing type 2 diabetes down the road. But they are being proactive. They're doing something about their health. And this is definitely a program that a lot of employer groups look to as far as in offering a weight management program for their employees that's evidence-based. So the vendor that Anthem chose here in California, and we partnered with them in July of 2016, is Solera Health. Now, the main reason I'm talking about Solera Health is because we have data provided by Solera Health to Anthem from July of 2016 all the way to current, because they're still currently our vendor. We do have another vendor that we offer here in California, but we don't have a lot of data on them because we just implemented them last year as another or secondary vendor for the diabetes prevention program for more flexibility. So a lot of the information that I'm going to be presenting to you right now is around Solera and what Solera does for the diabetes prevention program and Anthem Blue Cross members. So the big reason why we chose Solera in 2016 is because Solera is a network provider. They are not a DPP provider. So what they do is they go out and they partner with all of the DPP providers and they say, hey, partner with us. We have Anthem, a contract with Anthem to where we will filter them to you based off of the algorithms we set up, and individuals can join the program, and we pay you for your services. And Anthem pays us, and the pay cycle is perfect. Anthem doesn't have to go out and partner with each individual DPP provider. We partnered with one network provider, and they contract with everyone else. The other benefit of them doing this is because they have performance guarantees attached to all of these providers out there. So if they're not performing the way they're supposed to, they will pull them off of Anthem's network, because we only want high performing DPP providers out there. So we constantly on a quarterly basis analyze all of the DPP providers, whether they're digital or in-person providers, and find out how they're performing and what adjustments we may be able to do or put them on a performance plan to try and increase their ability as far as reporting or participation with members, or even abrasion issues that are developed with members. So we definitely have a great working relationship with Solera and their ability to manage their vendors. Another reason why we chose Solera was because it gave us the flexibility to reach our diverse populations, and they provide thousands of providers out there, whether it's digital or in-person classes. So it was meeting both of California's needs as far as diversity and flexibility to offer the diabetes prevention program. A little bit about the data that we have from the Solera program, and it's pretty interesting. I take this out to a lot of groups to where they say, well, you know, why don't we go with just a digital provider? And that's an option that we definitely have, but studies and statistics are showing us that individuals who participate in in-person classes are generally more likely, or 2 times more likely, to actually reach that 5% weight loss or more. And also when we look at age associated with individuals signing up for either in-person or digital platform, our older population is looking for that personal interaction in those in-person sessions as opposed to the digital platform. So on the graph in front of you, you can see, you know, our younger population, 18 to 24, strictly digital platform. That's their jam. That's where they go. And then as we increase in our age, we start to see a change in that. We start to see individuals really looking for what's around that flexibility. You will notice there's a color change from green to red, and this is our Weight Watchers DPP program. They are an in-person DPP program, but it's strictly Weight Watchers. So that's where you can kind of see some of these areas going, and then the 65 and up, really looking for that in-person classes. So if we have groups that have an older population, or an average mean of an older population, this is definitely beneficial to them, because otherwise those individuals really wouldn't be probably participating or enrolling within the digital platform, because they're really looking for that in-person platform. So how do we identify individuals for the diabetes prevention program? You know, CDC statistics tell us that, you know, 1 in 3 individuals is out there. And so if we go out to a work site, we say, hey, 1 in 3 of your employees or members or are at risk for DPP, that's not a complete accurate statistic, because 1, we didn't separate as far as 18 years of age and older, which you have to be 18 years of age or older to be enrolled in the diabetes prevention program. And you also have to be a non-diabetic. So this allows us to kind of shorten up our list, because Anthem does have data that shows known diabetics, and also allows us to filter for individuals 18 years of age or older. It allows us to target our population or our demographics to really focus on increasing awareness around the diabetes prevention program, and also allows us to reach out to members that do have diabetes and filter them through Anthem diabetes management programs. So when we reach out to these members, we can do it in 3 different ways. First way, which I don't really have here on the screen, is through their primary care physician that gives them a referral saying you are pre-diabetic. That is an option, and Solera does accept that within their enrollment process within DPP. However, the other 2 methods, we partnered with biometric screening vendors to collect blood screening measures. and to determine if individuals are at risk for diabetes or for prediabetes. And then also the online quiz. I would have to say 99% of the individuals that enroll within the diabetes prevention program here in California take the quiz and enroll through the quiz. It's just easier, it's more flexible. It's a 7-question quiz that individuals take, and then with Solera's platform, it automatically allows them to enroll within the diabetes prevention program and select their DPP provider. So there is a lot of flexibility in enrolling individuals within the diabetes prevention program. So how does Solera do it? And the best analogy I can give you for Solera's platform, it's like a dating website, to be perfectly honest. So an individual would go to soleraforme.com, and employer groups actually have the capability of adding to this to where it's specific to their organization. So it'll be soleraforme.com/XYZ, whatever they want it to be. And it'll have them take the quiz. And if they qualify for the diabetes prevention program via that quiz, it will say, okay, do you want to enroll in the program? And they say yes. So once they click yes, they start to take them through options to where it will tailor or recommend specific programs for them. So it gives them, do you want to do this computer-based or digital platform, or do you want it in a classroom? And in this example, we went the computer-based. And then it'll say, do you want individual participation or group? And then filters over to, is this a flexible schedule for any time, or do you want it specifically at the same time every single week? And then it will give them a best match option. So they get program A, B, or C. The unique thing is let's say an individual has a coworker that's in a program that really enjoys the program, they're seeing a lot of success, and they want to participate with them. They can drop all the recommendations that Solera provided them and pick that provider that their coworker is currently engaged in the program at, and Solera will sign them up into that same program. So there's a lot of flexibility to the program, which is, again, one of the reasons why we chose this vendor when selecting a DPP partner. Some of the outreach materials, and this is the more difficult part about reaching out to Anthem members. And as you know, every time a health plan reaches out to an Anthem member, most members look at the card and then throw it in the garbage. To be perfectly honest, reaching out to members as far as a health plan, it's a difficult task. So we utilize Solera to do the marketing for us, for the diabetes prevention program. How it's essentially done is when a client chooses they want to reach out to their Anthem members, we provide a data feed, which is their name, member ID, and contact information if they have email, if they have a mailing address, or even a telephone number. And then we do what's called, per Anthem's policies, we have to run it through a scrub of do not contact. If the member's elected or the client's elected to not have contact from Anthem, we will take their names out of the list, and then we send that contact file over to Solera, and then Solera does a campaign outreach, which consists of 4 to 6 emails of different strategy emails. They call it next gen email stratification, to where if an individual opens the email but they don't click on the next link to take the quiz, and the second email that's sent to them maybe a week to 2 weeks later has different call to actions and prompts to try and get them to actually click on the link and take the quiz, and so on and so forth. So their analytics around tailoring and targeting the Anthem members has shown to be very, very successful when we are able to outreach to those Anthem members as a whole. When we get into individuals signing up in the program, and most of you are probably thinking, well, how is this program paid for? So we have a contract with Solera that says, okay, you implement the program for a 12-month period of time. We're not going to pay you for 12 months. We're going to pay you as an individual participates through the program. And this is part of their preventative benefit. So we came up with a structure that is, one, focused around CDC recommendations for the diabetes prevention program pay plan, or pay for success medical claims submissions. And we put it in this format. So milestone 1 is when an individual either downloads their DPP provider app and enrolls in the program, or they are paired with an in-person class and establish a start date for that class. That's when milestone 1 is met. That's when the first claim is submitted and Anthem pays that claim. Milestone 2, or when the second claim is submitted, is at 4 weeks of participation. And if you recall, CMS, this is in support of CMS studies that this has a long-term saving of $2,650 per individual that participates in just the first 4 weeks of the program. So this is one criteria we are very interested in implementing in here, and one that we wanted to follow by when structuring this pay format with Solera. Milestone 3 is 9 weeks of engagement in the program, and then milestone 4 is 5% weight loss or more within the 12-month period of time. Now, milestone 4 can be generated at 9 weeks or further. So an individual could reach all 4 milestones, but continue to participate in the program for the rest of the 12 months. It's not a problem, it's not an issue. We just have these criteria built in here because we see this as being the more successful way to monitor or pay for participation within the diabetes prevention program. I'll go ahead and adjust the slide again, if it'll let me. This is a success story of the diabetes prevention program. This is actually one of the first clients that, or not clients, this is a member of one of the first clients that implemented the diabetes prevention program here in California. This individual enrolled within the diabetes prevention program. 10 months later, they lost 86 pounds and just had their 45th birthday. And the healthiest and happiest and lightest they've been in their entire adult life. And they continue to participate in the program and refer their friends and family within the program. So we do try and track as much as possible as far as member participation, enjoyment in the program, because we do know as a healthcare provider, there's a lot of programs out there to where you can implement it, but you don't get engagement, you don't get enrollment. This is definitely a program where we are seeing participation and engagement and benefits from the members that are grateful that this, the diabetes prevention program is offered to them by their health plan. I'll go to the next slide. And I think I have a few in the appendices. So if you had any questions regarding some of the data that we have in here or some of the studies, this is just a summary slide for you to look at. And if you want to take notes of it, you're more than welcome to. I'm not sure if they're going to be handing out the presentation deck to the total group later on or not, but if you have any individual questions, I'm more than happy to answer them for you. And with that being said, I can turn it over for questions.
I'm in phase here. Dr. Zaher, Chris, thanks for that that presentation. We do have a couple of questions. I have one that just has to do with that. You said members can enroll by PCP or doctor referral. Yeah. Anthem getting lab test results that are indicative of prediabetes, or the Solera questionnaire.
Mm-hmm.
How is that questionnaire sent to the member, or?
It's so when they do outreach to the member, it's basically an email that's sent to them and increasing awareness around what diabetes prevention is and the impacts of diabetes. And it gives them a link, are you at risk for prediabetes? And so you click on the link and it sends you to the Solera site, and then it takes you through the questions, the questionnaire. Once you answer the questions, then it filters you through the system. So it'll say you're at risk or you're not at risk.
All right, and that's not a blast questionnaire that goes to everyone. It's selected based on some lab tests or something else, or?
We have filtered it. It depends on the group. If the group says, look, I want to really target this campaign. I want it for individuals within this age range. I want it for individuals that, we do a scrub as far as for individuals that are 18 and older, and then also are not known diabetics. that is generally our contact file. We have worked with some client groups in the past where we've identified BMI as being one of those key criteria to really focus on. But then again, BMI isn't the key area that's going to put you at risk for DPP. There's many other factors. So we've encouraged our clients to really look at, hey, at a minimum, you're increasing awareness as far as if an individual is at risk or not at risk. And you also broaden the capability of more individuals taking the quiz and participating in the program. So let's just do a scrub for 18 and older and take our known diabetics out of the file, which gives us a pretty good chunk of the membership that we can target.
Right. Okay. Yes, I know some members don't like getting, well, mail at all.
Yes, we get pushback on that. But what's nice is when we partner with our employer groups, we co-brand with them. So when we co-brand with them, the employees look at it as it's, you know, this is something my employer group's sponsoring. I may want to participate in it. We've also had some clients that say, look, give us all the marketing materials. We'll send it via our internal distribution list to get more participation as opposed to Solaris sending it out. So there's a lot of different ways that we've done it.
Right. I have another question from Hattie, but let me just mention to the group that it was asked about a lunch break and have we put that into the agenda. And what we've done is that we've allowed all the participants to sort of self-select your break options. We didn't put in a formalized break for everyone for lunch. So that might be a good thing to do for our next session. But so for now, feel free to take, you know, whatever break you would like and can fit into the schedule. So there was another question about what the successful patients are doing regarding weight loss. I mean, we all know that have been, you know, involved in patient care that changing behavior is hard, and one of the most difficult aspects to change is weight. And now, in addition to touching your face, is also a very hard habit to break, but that's not diabetes. But have you found those folks who can actually get some weight? And it really doesn't, as you showed, it doesn't need to be a whole lot to have some impact. Do you find some, like 3 things that people do that really make them successful at that, or that you can help them do that makes them successful?
I mean, when specifically looking at the data that we get from Solera, we can see that there is a greater completion. I would almost say if you were to compare on-site DP providers to online DP providers or digital DPP providers, I'd say around 18% of individuals that participate on digital platform will reach that 5% weight loss or more. And we're looking at average here across the board. But when you look at on-site providers, they're up around 30 to 35% of individuals who sign up for the on-site classes reach that 5% weight loss or more. So I would definitely say the social interaction or dedication to saying, I don't want to let people down by not attending these classes becomes a factor in that. When looking at Anthem data, we're currently analyzing all 14 states where we've implemented DPP. Some of the areas that I'm hopeful they're examining are around hypertension, diabetes, really looking at individuals who sign up for the program but don't finish it and see what impacts their health has had over the past 2 to 3 years. And I'm very interested in this because it's a study that allows us to really look at, okay, 2 years before DPP started, now let's look at 2 years after DPP was first implemented and see what really has come about. And so I'm interested to find out the results of that analysis by our data team.
Thank you. Alissa, did you have a comment?
Yeah, so I was just gonna add in my experience with DBP over the last 7 or so years, one of the #1 things that we always see that's associated with successful weight loss outcomes is attendance. And so I think that agrees a lot with what you're saying, Chris, that it's that social interaction, and what motivates the social interaction, what motivates the attendance is the social interaction a lot of times. But essentially, if they're coming, they will almost always be losing weight. So it's really important that you make sure they're engaged. But attendance is like the #1 indicator of weight loss. So you just have to get them there.
And Bernadette.
Hi, this is Bernadette. So I totally agree with what Chris and Alissa are saying. Definitely what I've seen with those patients that I have data for that have the most weight loss, they've actually attended almost every week, all the sessions. And then also those patients that are coming in almost every week, they're giving me very detailed reports on their food log, their physical activity log. So for example, with their food log, they're really tracking what they eat for breakfast, lunch, dinner, their snack time. They're documenting their portion sizes, and they're also documenting their calories. So with those combined, I think they're really tracking their calorie intake and output. So I definitely see like the top 5 patients that I've seen lose weight, they all do that. So that's just my input on that one.
And if I could add a few points too, I'd say that one of the key differences in looking at the data that I see across the board, especially when claims come in, for our in-person classes, individuals, they have a set date 1 time a week that they go in, and then once they reach that 16 weeks, it moves into 1 time a month. On the digital platform, we're seeing individuals' participation, they reach that 4-week milestone significantly sooner than 4 weeks because they're able to complete all the activities in a shorter period of time. So they get on their digital device and they keep completing activities. So as far as receiving claims, I think there almost is that period of time where a person says, look, I'm going to push through all these activities and then I'm going to have a break in time for a little bit. And then I'm going to rejoin in a break in time. So whereas the in-person classes, it's consistently every single week for 16 weeks, which helps helps develop that behavior. So there is a lot to say or benefits around the in-person classes versus digital. And it's not to say digital is not bad, because some individuals, it might be that's what they need. But it's great to have that flexibility.
So 2 points around that. I haven't heard anybody mention any, like, other than losing weight is a reward in itself, but any other type of reward systems placed into the program. And then the second question would be the effect over time. Once either the sessions get less or non-existent after the period of the program is over, do we revert back to where we were before? Or do you have any data on that?
So for Anthem, it's not just a one-time benefit and you're done. You can sign up for DPP, do it for 12 months, and if you re-qualify for the program, meaning you're still at risk, you can enroll in the diabetes prevention program for a 2nd or 3rd year. We do have members that have gone in the program for 3 years now, and they're consistently reaching that 5% weight loss, but they're still at risk due to other factors or whatever it falls into. So I would say that part of our analysis is going to look at what has happened to the members that participated the first year and then did not participate in year 2, year 3, so on and so forth. So I'm interested to find out a little bit more when we comb through all that data. And then what was the other question you had?
Well, it was basically like any kind of rewards other than the reward itself of losing weight and getting your risk reduction.
There is the built-in Fitbit or the wireless scales, which individuals tend to like. There are some employer groups that tie it around incentives to where when an individual reaches a certain milestone, it credits them for incentives associated with those organizations, and either accumulating points or however they structure their incentives. We just provide reporting out so that they can be accurate on individuals' progression through the program. But outside of that, I mean, physical activities tracked. you know, nutrition-wise, a big part of DPP is actually, you know, working with individuals on, you know, what is nutrition. When you go into a grocery store, how do you shop? Do you shop around the perimeter, or do you shop within specific aisles? How do you do it? And getting into that behavioral change to where people are more aware of what they're doing.
All right. Well, thank you. I think we're going to go to some polls now. Alissa, do you want to set up the next bit of the discussion?
Yeah, I do just want to really quickly add in a couple of extra thoughts based on some of the questions, from some of the questions that were asked right after Bernadette's presentation. The one around use of CHWs or promotoras in CPP and DSME. So just quickly, for DPP, absolutely, lots of people use CHWs to do DPP. Also with DSME, you can use CHWs as long as they're not the ones who are teaching the majority of the program and the patients are still able to access healthcare professionals to answer some of their more clinical questions. You can absolutely have a CHW sort of teach the majority of the program and then have some sort of health professional come in at the end to answer any of the questions. So that's a really great option, especially to sort of help mitigate some of the high costs of having clinical professionals teach the full hour of the program. So there's definitely the option to use CHWs for a DSME program. The other question about online options, as was mentioned, absolutely, there's online DPPs available. The reimbursement for those haven't caught up yet for all different folks who are providing reimbursement for it, but hopefully that will happen in the next few years or sooner. And then for online DSME, I remember hearing, I can't say for sure, but I remember hearing about there being some online DSME programs, and there's no reason that there really couldn't be sort of an online DSME program, or at least one that utilizes some telemedicine. So I don't know, but I'm going to look more into that because I'm also curious. I feel like I've heard about it, but I'm not entirely sure if there actually are still online DSME programs folks can use. And when I say CHW, I'm meaning community health worker, which is just sort of a more catch-all phrase for a health educator or someone who works out in the community. So CHW is kind of a broad term that can be used for a lot of different people, but if you're familiar with the term promotora, that would be an example of a community health worker. So that's sort of what we mean when we say CHW or community health worker.
Great, thank you. So do you want to go to the polls next?
Sure. Megan, do you want to next the slide? There we go. Do you want to introduce this, Dr. Zaher?
Yeah, so, you know, we've been talking a little bit about one of the main focus points we have for the Right Care Initiative, particularly this year, although it's always been as part of the program, is, you know, how do we take what we know from a scientific knowledge base and really translate it and implement it and you know, where the rubber meets the road and actually get things going. So there's some questions we have regarding that. And this one is just, you know, you've listened to the last two presentations that did focus on programs to take the science and put it into action. So if you vote on this on a scale of 1 to 5, with 1 being not feasible and 5 being very feasible, how feasible do you think it would be that your organization will be able to pursue starting or referring out to these types of programs previously mentioned? So if you could enter your answer, and then we'll see sort of where the group is as a whole.
We're at about 20%, so you guys can continue to submit your answers. Great, we still got some answers rolling in. Be great if we could get up to 30% participation.
And by the way, while you're answering the questions, just to let you know, at the end of the meeting today, we'll let you know about how to get CMEs for this wonderful presentation. That's the prize at the end of the meeting. Okay, are we?
Okay, Megan, do you and I? Oh, yeah.
Okay, well, 55% very feasible. That's encouraging. 5% not feasible. Well, not as encouraging, but there are always challenges in issues like this. So between 4 and 5, we've covered 85%. So that's actually rather encouraging. We have the next poll. Okay, so this question has to do with what would it really take for your organization to start or refer for these types of programs, and you can answer more than one. So these are sort of what are your challenges? What do you really think that you need to be able to get something like this jump started? Do we have some answers?
We're at about 22% participation right now.
Okay.
We'd love to hear from you guys so that we can use some of this information. That's absolutely the plan, is to use some of this information as to what sorts of things would be helpful to roll out more of these programs or get more referrals into these programs. Please do share your thoughts so that we can try to focus efforts in these areas. We're at about 25% right now.
Do
you want to publish, Megan?
Okay. Now I've been informed that we could have included some other options, one of which is our organization already does this, or we already refer out to a DPP program. So we don't have that as an option here. So this poll would predominantly be relevant to those organizations that have not done it yet. So more data on health outcomes, personnel to implement the program, funding, which is always a major issue, training, organizational support. I suspect that's from the leaders in the organization to get the organizational support and consistent positive efforts going. And quick and easy referral, that's always helpful. And more access and availability of programs. Okay. All right. Do we want to open up any questions from any of the participants at this point? I don't see any other questions in the queue. Although I did want to know if the participants are keeping the weight off. And I think, Chris, you referred to that a little bit in your answer before. But do we find that those weight loss efforts really are sustainable? And Bernadette, you also had weight loss in your 50% roughly of your participants. Is it something that's sustainable for the most part, do we think?
I can also speak to this if you want. Just a quick comment that in general, I would say most people, as you can probably imagine, do gain back some of the weight. That absolutely happens. Most people don't keep the weight off long term. However, in the original research studies that were done on this program, where they absolutely still are tracking this work, in fact, our very own Dr. Carol Watson is part of this project still. It's an ongoing study, the original DTP study. And though people do gain back the weight, they still see health outcomes, health benefits long-term, even when they gain back the weight.
Oh, okay, well, that's interesting.
And then we do have one other question, Carol, if you wanted the chat box question, if you want to next to that, or we could take a break. It's up to you.
You know, I don't see that question.
Megan, can you next the slide? This is sort of covered on the last one, but if there's other things people want to add.
All right, right. If there's anything folks have that are real potential barriers to really implementing some programs such as these, if you could include those in the chat box and we'll just tally that up. We're about 4 minutes from starting our next topic. That's a very short break, but it might give folks a little break. Why don't we plan on having just a little 4-minute break as a quick stand up and stretch or do whatever recharges your mind for the next session. And then we'll start at 1:25 and I will hand that over to Keith. Dr. Keith Emmons, you're on the line here, I see. So at 1:25, will you be able to introduce our next speaker?
Can you hear me now?
Oh, now I can. There you are.
Yeah, I said, yes, I'll be ready to start.
Okay, so at 1:25, we'll get started after a very quick break. Thank you.
Hi, everybody. Thanks so much for participating in our first ever virtual meeting of the Right Care Initiative. We have been trying for several months now to see if we can do live webcasts of our in-person meetings, and we have been having various technical issues that have prevented us from doing that, but I would love to hear people's thoughts on whether once we get back to normal activities, which hopefully will be soon, people would like to rotate between webinars and in-person meetings. Any comments from our leadership, from the audience?
Well, this is Dr. Zaher. From the audience perspective, just looking at our participants, we were up to 90 at one point, which is, quite a nice sized group that we don't usually get on site, just looking at numbers.
This is
Well,
Dr. Keith. I was going to mention the same thing. This webinar has enabled us to reach a much wider audience, and I think that even when we are able to get back together and see people in person, it will be wonderful to still keep this going because more people will be able to attend.
I'm also hoping that we can record these sessions and make them available for people to obtain their continuing education, even if they're not able to participate at the time that we put the event on. So that notion of enduring CME is one that I know that Alissa has been exploring at USC. Alissa, could you say a few words about that if you're back from your break?
Sure. So it's absolutely something that can be done. It's just fairly expensive. So it's, I don't remember the number off the top of my head, but I want to say something like $5,000 per year to host an enduring CME online. So it can be done, but it is costly.
So 5,000 is per year or per session?
It's per year, per session. So if we had multiple sessions, it would be $5,000 per enduring CME per year.
It sounds like this is going to require some further, deeper conversation offline. Is Dr. Kransdorf available? I have him, but he's on mute, I see.
No, he's fine now.
Can you guys hear me?
Yes.
Now we can. Okay.
Yep.
Great.
I am here.
Thank you for joining us.
It's my pleasure. Thank you for having me. Can everyone hear me okay?
Yes.
Yes.
Okay, great.
What I wanted to do was, this is Dr. Keith Emmons. I wanted to introduce Dr. Evan Kransdorf. I first started looking up to Evan about 3 years ago, January of 2017, and didn't realize it at the time, but it made sense when I later found out that he completed both an combined MD and PhD degree at the same time with Virginia Commonwealth University. He completed his residency in internal medicine at Duke, another stellar institution, and followed by a cardiology fellowship at the Mayo Clinic in Arizona. And he is now over at Cedars-Sinai Medical Center, where I met him. He is currently an attending physician there at Cedars-Sinai with the Advanced Heart Disease Program and assistant professor of medicine. His research interests, which I think he'll touch on a little bit today, include the genetics of the cardiomyopathies and heart transplant allocation. So without any further ado, I'd like to introduce everyone to someone who's become a good friend of mine, Dr. Evan Kransdorf.
Well, thank you, Keith, for that very kind introduction. It's really a pleasure. It's been a pleasure to work with you, and it's a pleasure to be here today to talk a little bit about what we're interested in and some of the new innovations in management of cardiomyopathies. It's actually been a very exciting kind of couple years for cardiomyopathies because we've seen a lot of innovations in treatments for cardiomyopathies. And I'm going to highlight some of those innovations today, and I think ultimately those innovations will translate into improved outcomes for patients with heart failure and cardiomyopathies, which is something that we're very excited about. And I don't know what everyone else is seeing, but I am not seeing my slides as of yet.
Yeah, I'm not either. Megan, are you able to put up his slides?
There it comes.
Sorry, pause for technical difficulties. I am getting it back.
While she's doing that, I will be watching and monitoring the different questions that you may submit through the Zoom webinar chat. And at the end of Evan's talk, we'll go over those questions. And here we go.
Okay, Dr. Kransdorf, I have given you remote control of the slides.
Okay, great. I'm trying to see if I can. Okay, great. Yeah, so great. Thank you. So my talk today entitled Innovations in the Diagnosis and Management of Heart Failure with Reduced Ejection Fraction. And I just wanted to really start with some overviews of heart failure with a reduced ejection fraction. And even before that, I'll just go through some of the objectives of my talk. First, to provide an overview of the epidemiology of heart failure in the United States. Number two, to highlight some of those kind of new therapies that I mentioned, the first of which being a drug that's been out for a few years now called sacubitril/valsartan, which is a combination of two medications, and an even newer class of medications that basically are, within the just starting to be implemented in the clinic, and those are the sodium glucose cotransporter 2 inhibitors, also known as SGLT2 inhibitors. The third objective is to discuss the use of cardiac rehabilitation for heart failure with reduced ejection fraction. And then lastly, as Keith had sort of alluded to, I wanted to talk a little bit about one of my interests, which is the role of genetic testing in the evaluation of patients that have dilated cardiomyopathies. Sorry, there's a little bit of a lag trying to get my slide to advance here. There we go. Okay, so starting on a little bit of overview here. So heart failure is one of the most common medical conditions that exist in the United States. Using the NHANES survey from the NIH from a few years back, it's estimated that over 6 million Americans have heart failure. And of course, as we're all very well aware, the prevalence of heart failure is very much age dependent. With a smaller number of persons affected by heart failure in younger ages and a significantly increased number of patients as they get older. But still, it's a huge burden on society. And the most common reason that people are hospitalized is for heart failure. So, although it is, it's important from a sort of a personal and patient perspective, is a huge issue to society because it is such an incredibly common medical condition. Trying to advance. There we go. Oh, I think there's a little bit of a lag. So heart failure is a mix of patients that have heart failure with reduced ejection fraction, patients with a mid-range ejection fraction that we sort of define as sort of between 40 and 50%, and patients with a preserved ejection fraction where it's over 50%. And in general, there's been a trend over the years for there to be less patients with heart failure with reduced ejection fraction and more patients in the sort of mid-range ejection fraction and preserved ejection fraction range. And I think that necessarily doesn't represent a change in the pathophysiology of heart failure, but it may likely more reflect our recognition of patients that have heart failure with preserved ejection fraction as such. Whereas before they might just be caused someone that has shortness of breath or something like that. Now we're recognizing that it is a distinct phenotype. In general, survival for patients with heart failure, regardless of ejection fraction, and as you see, the kind of different types of heart failure are there in the different colors. The survival for patients with reduced ejection fraction, regardless of the ejection fraction, is reduced. So we see there in the kind of light blue is patients with heart failure with reduced ejection fraction. Orange is those patients with the mid-range ejection fraction. Gray patients with preserved ejection fractions. And we see that the survival rates are actually relatively similar between the different groups. Now, what's not shown in this figure and is generally not very well studied is the younger patient population, like when we're looking at patients when they're in their 40s and their 50s. And those, because obviously patients in these older groups, they likely have a lot of comorbidities, such as ischemic disease, that contribute to their heart failure. It's not uncommon that patients who have younger, or patients with heart failure who are younger, actually are more likely to have a dilated phenotype, which in itself is more likely to be genetic. And those patients would be even further than this, where we would see that they have a much higher median survival based on their life expectancy, and we see more of a divergence between the survival in patients with heart failure with reduced ejection fraction and those other groups. The way that heart failure clinicians assess patient symptoms is we really use the New York Heart Association functional class. We ask patients about their dyspnea, their symptoms with exertion, if they have any apnea when they lay down to go to sleep at night, if they wake up with shortness of breath, ICD shocks, all these different things that we sort of categorize in every visit, and we place them in one of these four functional classes, New York Heart Association class 1, 2, 3, or 4. Now, it's very easy to identify patients who are in class 1 or class 4. Class 4 are patients that are having symptoms at rest. Class 1 are patients that are having no symptoms at all. It can be a little bit more difficult to select patients who are in class 2 and 3. 3, we would say, are patients that are having symptoms with less than sort of normal exertion. For example, people should be able to, generally speaking, go up the stairs. If they're having shortness of breath going up the stairs, we're probably going to put them in a class 3. 2 would be someone who's having shortness of breath at kind of longer amounts of exertion. But, there's a lot of wiggle room between these different classes, and it's obviously very subjective. And certainly studies have shown that there's a great variability and actually outcomes for patients in these different groups, likely because it is a relatively simple sort of catalog of symptoms that allows us to label them into different groups. But the reason why I bring this up and why I have a slide on it is just that it's important because this is one of the ways that we use to determine what medical therapies are suitable for patients, and that's something that I bring up in all my different slides is sort of what functional class the patient is, and that helps us determine what medical therapies we'll recommend. And the way I approach this lecture is I really go case-based, and I think that's advantageous because it kind of helps you identify a problem for in the patient and what you're going to do for that problem. So I have 4 cases that I'm going to present, and they sort of align with my objectives 2, 3, and 4. And I kind of go through each case and talk about how we have a therapy that may help that specific patient. So this case 1, Mr. L, a 59-year-old gentleman who your partner is who's conveniently on vacation. He has a history of dilated cardiomyopathy with an ejection fraction of 30%. He had a normal angiogram at the time of his initial evaluation. His EF has been persistently depressed. He had an ICD placed in 2014, which has not discharged. When you talk to him, he has about New York Heart Association class 2 symptoms. He's generally pretty active. His heart rate is 65, blood pressure is 110. He looks pretty euvolemic on exam. Labs look pretty good. He's on a little bit of Lasix, some lisinopril, some carvedilol, and some eplerenone. So kind of what's the next best step on management? So for this patient, I think this patient would benefit from changing lisinopril to the combination medication sacubitril/valsartan. And for us heart failure transplant cardiologists, we kind of think about sacubitril/valsartan as kind of being tantamount to being Superman. Because this medication is something that obviously we've seen the studies, but in addition to that, we have seen a significant benefit from in patients, seeing that patients have felt better when they've been changed this medication, and certainly we've seen improvements in ejection fraction. And that's something I'm going to kind of go through a little bit more detail in terms of the study that was used here. So see if I can go back one slide. There we go. So sacubitril/valsartan was studied in the Paradigm HF study, and this was published in the New England Journal in 2014. I just want to go through a few of the specifics of that study. It looked at patients with New York Heart Association Class 2 through Class 4 heart failure. Initially, the inclusion criteria was an ejection fraction less than 40%, which was later amended to 35%. They do that to try and increase the event rate. Patients were required to have elevated BNP or N-terminal pro-BNP levels. They had to be on stable medical therapy for at least 4 weeks. And patients were excluded with low blood pressure or low kidney function or hyperkalemia or history of angioedema. Patients were run into the study, meaning that they had to be treated with enalapril first, and then they actually were treated with sacubitril/valsartan. So that way, it was known that patients tolerated both medications, and then the patients were randomized to either one versus the other. And the primary outcome was cardiovascular mortality or heart failure hospitalization. So here are some of the main results from that study, which I think are really important. And the sort of older name as what kind of during development for this medication for sacubitril/valsartan was LCZ696. So that's kind of what you see there on those plots. So in plot A there on the top left, when we look at the primary endpoint, which as we mentioned was a combination of death and hospitalization, we see that there was a hazard ratio of 0.8, meaning a 20% reduction in that outcome for patients that were treated with sacubitril/valsartan. And then if we kind of stratify in B by death from cardiovascular causes, again, we see a 20% reduction. In C, if we look for hospitalization, we see a 21% reduction. And then if we look at D, death from any cause, we see a 16% reduction. So for a multitude of endpoints, we see that sacubitril/valsartan was better than enalapril in this patient population, and which was and is one of the largest clinical trials ever performed in patients with heart failure and reduced ejection fraction. Now, the next question I'm sure you have is, well, what about adverse events? This medication must have had some side effects on patients. In general, this medication can cause hypotension, and that's not too surprising because basically it's a combination of two medications. One of them, valsartan, is a known angiotensin receptor blocker, and then the novel kind of part to that is sacubitril, which is a neprilysin inhibitor. And so as a combination of two medications, they did see hypotension more commonly, 14% of patients with the sacubitril/valsartan versus around 10% or so with enalapril. But interestingly, they actually saw less creatinine elevation with the combination medication. They saw less cough, they saw less hyperkalemia, and no difference in angioedema. So when I start patients on this medication, what I tell them is, yeah, this medication I think will help you. Just, we always have to be wary that it can cause hypotension, and that's something we monitor for very closely when we start patients. And we generally also are very careful about their diuretics, and we find that sometimes by reducing the diuretics when we start this medication, that can help mitigate some of the effects of the hypotension. Now, this is a kind of a sub-study of Paradigm HF that looked at ejection fraction and these different outcomes. And basically, what they find is that no matter what outcome they look at, for any sort of range of patients with a reduced ejection fraction, they find that there's still a benefit of the medication. So that's very reassuring that there's not sort of any upper limit within the heart failure with reduced ejection fraction range, which generally we define as an EF less than 40%. We see that there is improvement of sacubitril/valsartan over placebo. Some additional benefits and pearls of this medication. In general, when we look at patients, we find that patients who are treated with sacubitril/valsartan over enalapril had more loop diuretic dose reductions. So saying it another way, it seems like this medication helps people reduce their diuretic requirements. As I mentioned before, we see less episodes of severe hyperkalemia with this medication, which is also very nice. Now, some pearls in terms of implementation, we don't like to overlap. So generally speaking, especially for ACEs, we will hold that for 3 days, or sorry, 3 doses before we start the combination medication. There's 3 doses, but I'd say in practice we use 24, 26, which is the lowest dose the most commonly, again, because these patients tend to have lower blood pressures, so we have to tread very carefully. We always recheck their renal function after starting. And then there's a lot of different data about monitoring their natriuretic peptide levels. Some times the natriuretic peptide levels actually go up initially with this medication because the neprilysin, which is the kind of pathway in the body that Entresto inhibits, it actually there's interaction with BNP, so sometimes we actually see the BNP levels go up as we start the medication. There's also been some additional studies looking at the benefit of sacubitril/valsartan in acute heart failure, and that was the Pioneer HF study that was published just recently in 2018. And basically, they randomized patients at the time of discharge to enalapril or Entresto, and the primary outcome was the time averaged change in the N-terminal proBNP concentration. And what they found was that patients that were randomized to sacubitril/valsartan had a very significant decrease in their BNP levels on sacubitril/valsartan versus enalapril. So basically, these data support the use of sacubitril/valsartan in our patients with heart failure reduced ejection fraction and show that there is a significant improvement in outcomes with using this medication. Now, the one thing that's interesting, and I wanted to highlight a little bit, is that although the FDA approved sacubitril/valsartan for use in patients with New York Heart Association Class 4 symptoms, there were only 60 patients in the study, the original study, that is Paradigm HF, that had Class 4 heart failure. And of course, that only represents about 0.7% of the full study. So it was a little bit curious to me that they were willing to approve it for that population. So something that we at Cedars are part of is a study specifically looking in this Class 4 patient population, in a study called HFN Life that is still ongoing. It's almost a completion. It was supposed to enroll 400 patients with an endpoint of looking at their natriuretic peptide levels. We're at an enrollment of somewhere around 350 patients, so it should be coming to a conclusion soon, but we're still not quite there yet. But this is going to really help us answer whether these patients with New York Heart Association Class 4 heart failure, whether they really do benefit from sacubitril/valsartan, because there was such a small amount of patients in the original study with this degree of heart failure. Okay, moving on to my second case. You're seeing Mrs. G, a 72-year-old woman with ischemic cardiomyopathy and diabetes mellitus. She walks daily for about 15 minutes without symptoms. On exam, she looks euvolemic. Let me go back one slide, please. Thanks. She has an echo that shows a ventricle that's probably mildly dilated with mild mitral regurgitation. Next slide. Thanks. Her vital signs look good. Her physical examination is benign. Laboratory testing shows normal potassium and creatinine. Her medications show Lasix, Entresto, Carvedal, Eplerenone, Metformin. Are there any other additional medications that may be beneficial for this patient? So this is a pretty big moment for the heart failure community. Let's go back one slide. Thank you. So just recently, you can see the date on this article was November. This new medication called dapagliflozin was found to be helpful in patients with heart failure with reduced ejection fraction. Now, what's really interesting is this actually was a medication that was originally developed for patients with diabetes. And as I mentioned, it's an SGLT2 inhibitor. So this was very exciting, and I'm going to talk a little bit about this study and what it found. So basically, the way the story unfolded is that there was an early signal for cardiac benefit in studies of these SGLT2 inhibitors in patients with diabetes mellitus. So what they did in this study was a randomized study of dapagliflozin versus placebo for patients with New York Heart Association class 2 to 4 heart failure with an ejection fraction of 40% or less. One of the other important inclusion criteria in this population, because many of these patients will have renal dysfunction, was a GFR of greater than 30. So just looking at some of the plots from the paper, looking at the different outcomes, so looking at the primary outcome, they found that the hazard ratio was 0.74, a 26% reduction. And then again, looking at the combination of the different outcomes, hospitalization for heart failure, 30% reduction. Death from cardiovascular causes, 18% reduction. Death from any cause, 17% reduction. So clearly, these drugs have a significant improvement on outcomes for patients in this population. And the other thing that I thought was really fascinating is that although this was a medication that was developed for patients with diabetes, there was no difference in outcome in this study whether patients had diabetes or not. So that sort of, I think, confirmed people's sort of feeling that this medication was really something that was acting directly in the heart failure process, because it wasn't, the effect didn't differ whether people had diabetes or not. The thing that is important about the study that I think requires some caution is that only about 10% of patients in this study and the DAPA-HF study were on valsartan and sacubitril. So we don't know what would happen if patients were on, if more patients in the study had been on that medication. It's possible that there would have been a smaller effect. That's just something we don't know, and we may never know, because given the benefit that was seen in this study, it's unlikely that someone is going to take a separate study and look at that, look at the use of this medication in patients that have high levels of treatment with sacubitril valsartan. Now, pearls about using dapagliflozin are that it is important to watch the volume status, because one of the ways it works is it inhibits the reuptake of glucose in the kidneys, and so volume depletion is something that can occur in certain patients. Obviously, the effect of the new medication on the patient's blood sugars needs to be carefully monitored, as well as the effect of the medication on people's renal function. Excuse me. The mechanism of benefit for this medication is still very much unclear. It does increase diuresis, as we kind of mentioned. It also has some effect on afterload reduction, but there's also some interesting basic science studies showing that it does increase the secretion of erythropoietin, and that patients who are treated with this medication, they actually note that they have an increase in hematocrit and hemoglobin. So that's thought to be potential benefit of this medication. And also it may improve myocardial energy uptake. So it's not entirely clear how it works yet, but obviously it does have a significant improvement in outcomes for patients with heart failure and reduced ejection fraction. And I think it's something that will increase in utilization in this population over time. It's still pretty new. I only have 1 or 2 patients that are on this medication, but I think it's something, again, that will continue to increase over time. I'm going to take a break to have a drink. I'll be back in 1 second. Moving on to case 3. So this is Mrs. H. She's a 72-year-old female patient who was recently hospitalized for heart failure. It's her second hospitalization in the last 6 months. She continues to have New York Heart Association class 3 symptoms and poor exercise tolerance, but has no specific heart failure symptoms such as orthopnea or PND. You repeat an echo in the office, which shows an ejection fraction of 30%. That's been pretty stable over the last year. So kind of looking back at some of the data going back a little further, exercise training had actually been shown to improve functional capacity in patients with heart failure. But the question arose was, could exercise training actually decrease hospitalizations and improve survival in patients with heart failure and reduced ejection fraction? To answer this question, the HF Action study was developed. And this ended up being a study of around 2,300 patients with an ejection fraction of 35% or less who had New York Heart Association class 2 to 4 symptoms despite being on optimal medical therapy. And this was published in JAMA now a little more than 10 years ago. And interestingly, a little bit different than those other medication studies that we looked at, specifically the Paradigm HF studies and the DAPA HF studies, there was no difference in all-cause mortality or all-cause hospitalization when you just looked at all comers and you didn't do some statistical controlling. The hazard ratio was 0.93 with a p-value of 0.13. Now, when the statisticians did some corrections for different factors which affected outcome, they did see a modest benefit on the primary outcome. They saw a hazard ratio of 0.89 with a p-value of 0.03, but I think we can agree that's a relatively small effect. And they did not see a effect on all-cause mortality. Secondary effects, however, included a greater increase in 6-minute walk and a greater increase in maximal oxygen uptake. And it was as a result of this study, actually most insurance companies approved cardiac rehab for patients with heart failure with reduced ejection fraction. And this is, I think, a really happy story. This is something that we employ in our heart failure patients all the time, because I believe sort of what happens to these patients is the lack of sort of cardiac function, leads them to kind of down-regulate their exercise, and as a result of that, they develop deconditioning. So kind of aside from the cardiomyopathic process, they have some sort of general myopathy that's related to just a lack of exercise. And that's something that I think can really be improved as a result of cardiac rehab. And so basically any patient that I can convince to get into cardiac rehab with ejection fraction less than 35%, I send them. And I think it's really beneficial. There's additional data that I haven't really, didn't really go over here, that cardiac rehab actually decreases depression, because depression is very comorbid in heart failure, as we could all imagine. So, I think cardiac rehab is a really important non-pharmacologic tool that can really help patients. And again, it may have a small effect on their overall mortality and sort of heart failure hospitalization, but I think it has a bigger effect on their functional status and potentially their mental well-being as well. So moving on to the next case. Case 4. So Mr. G is a 63-year-old gentleman, a history of dilated cardiomyopathy, initially diagnosed about 10 years ago. He required a pacemaker about 6 years ago for a complete heart block. On interview, he's doing very well. He's very physically active, reports New York Heart Association Class 1 symptoms, goes to the gym, exercises, which is pretty remarkable because his, ejection fraction is pretty depressed, 20-25% with a dilated left ventricle of 62 millimeters. He did have a coronary angiogram at the time of diagnosis that was negative. And part of his visit with you today was not only a checkup, but also to discuss that his son was just diagnosed with cardiomyopathy. And so he's, obviously very concerned about this and kind of wanted to review his family history with you. So it's a pretty interesting and I think important family history. His father died at a young age, 51, of a, quote, heart attack. He hadn't been a smoker or anything like that, but he just, kind of one day kind of suddenly died, and they were told it was a heart attack. His mother is still alive. He does have a brother that has cardiomyopathy, and one of his sisters has cardiomyopathy as well. So dilated cardiomyopathy, and just to be clear, when patients have cardiomyopathy, not only are they a mix of heart failure with reduced ejection fraction and preserved ejection fraction, as I mentioned, the cause of the heart failure is pretty much a split between patients with ischemic disease and dilated disease. And when we say dilated, what that means is the heart becomes enlarged, the walls actually become thinner, and ejection fraction goes down. And there's no obvious cause for it. When that's true, we call it idiopathic dilated cardiomyopathy. And what we're finding with kind of better sequencing is that rare variants are found in patients in sort of a set of genes and are associated with the development of dilated cardiomyopathy. And this pie chart here is sort of a study from Europe from about 5 years ago that looked at all the different genes that are found to be have rare variants in patients with dilated cardiomyopathy. And in general, that number of genes is somewhere around 50 genes. And I want to talk a little bit more about that as we go on here. This is an Italian study that just recently came out, and they looked at 12 genes. And what they found is that these 12 genes that I have listed here explained a good portion of the cases of cardiomyopathy in their cohorts. And when they look at these 12 genes, what they found was that they found variations in these 12 genes in 17% of cases in an unselected cohort of patients with dilated cardiomyopathy, and 26% of cases in a selected cohort of patients that were specifically referred to a clinic with dilated cardiomyopathy that also they wanted them to have genetic testing. So this was basically a cohort that was probably slightly enriched for cases that were genetic in origin. So although 17 and 25% don't sound like a lot, that actually is a lot to me, because that means in every one of these families, there may be other people that have dilated cardiomyopathy, which I think is really important. The other thing that's important about looking at the genetics of dilated cardiomyopathy is that most studies have focused on Caucasian and Asian populations, and unfortunately, African American patients and Hispanic Latino patients have been underrepresented in studies of genetic epidemiology. We at Cedars are very privileged to be part of a study called the Dilated Cardiomyopathy Precision Medicine Study. It's an NIH-funded study. It's at 26 different sites throughout the United States, of which Cedars is one site. And the goal of the study is to recruit 1,300 probands with dilated cardiomyopathy, as well as their family members, to try and get a better assessment of the genetic epidemiology of dilated cardiomyopathy. In addition, to specifically help to understand the genetic epidemiology of dilated cardiomyopathy in African American and Hispanic Latino patients. This study is also nearing completion. Currently, the study is enrolled around 605 or so Caucasian patients, about 510 African American patients, and about all 100 Hispanic Latino patients. So it's almost completed, although not complete. And so we should have data that starts to come back from the study within the next few months to a year or so. And the other, I think, exciting thing about this study is that there's going to be several sub-studies. We're actually involved in a magnetic resonance imaging sub-study of this study, and there likely will be follow-on studies as well, larger studies to try and continue to understand the genetic epidemiology of dilated cardiomyopathy. As I mentioned, the study is not yet complete. Expected enrollment should be completed over the summer. And then some preliminary results from the study, from the data cuts that we have so far, is that about 1/3 of the families in the study have more than one family member that has cardiomyopathy. And about 2/3 of the probands, that is, we use the proband, the term to mean the person that has the cardiomyopathy, about 2/3 of the probands were found to have a genetic variant that can potentially explain their cardiomyopathy. So these are very exciting results, and I think we'll have more information on this when the final study results come out in the next few months, years. So a little follow-on about this case. So for this patient, the gentleman that presented with the son that was newly diagnosed as having cardiomyopathy, genetic testing was sent and revealed a pathogenic variant in the lamin A gene, and that specific mutation is there. This gene, which encodes the protein lamin A, comprises about 5% of cases of dilated cardiomyopathy. In general, asymptomatic lamin genotype positive family members have a 10% annual incidence of new cardiomyopathy, meaning that if he has one of his other sons that doesn't have cardiomyopathy at this time, if he tests positive for the gene, 10% chance of presenting with cardiomyopathy every year that goes by. And then overall, in a cohort of about 80 or so patients with lamin mutations that were followed, about 20% of patients with lamin needed heart transplants over 8 years. So lamin A does tend to be a gene that we're very familiar with. We follow quite a number of families that have lamin A mutations in our cardiomyopathy and transplant clinic. and it is sort of a bad actor, if you will. So that's really all the information I have, and I did end a little bit early, but I'd be very happy to answer any questions and kind of delve into a more in-depth discussion of some of these topics.
Evan, thank you very much. This is Keith. I'm waiting for some questions to come in, but I thought I would start by asking you a couple of questions.
Please.
The last thing that you just mentioned was your 10%, this is cumulative is what you're saying. So that, are you saying that we can now, maybe with this genetic defect identified, we can predict who will need transplants in the future?
So that's a very good question, and that's something that people are still actively working on. And there is some work in this area. There's definitely some work about laminin mutations and the risk for arrhythmias, because the other thing that is common in patients that have laminin mutations is they have a lot of arrhythmias and require defibrillators and defibrillator discharges. There actually is some recent work in the electrophysiology area developing a kind of a risk score to kind of help identify patients that have arrhythmias. And I'm hopeful that through studies such as the dilated cardiomyopathy precision medicine study that we're involved in, that at some point in the future we will have a risk score where we can say, hey, the likelihood based on your the variant that your family has, the likelihood you're going to need a transplant is X. Because I think that at this point in time, we don't know that, and it's just something that we continue to follow closely. But hopefully that's something after more time and more research, we'll be able to have where we can tell people that because they have certain variation or certain characteristics, that the likelihood that they will need a transplant in their lifetime is whatever it may be.
A follow-up to that would be, and it may be too early to tell, when you stratify out by race, so Caucasian, African Americans, Hispanics, have any preliminary data come out as to the predictability, either increased or decreased in any of these groups?
So that's a very good question, and we don't yet know the answer to that, and that's something that we are very keenly interested in, and we will be looking at in the study. In April, actually, we were supposed to have our annual meeting for the study, which unfortunately is going to need to be only on the web because of the coronavirus. But hopefully we're going to get some information about that very question. And I think that's a very, very important question that needs to be answered.
Then at the very least, would you encourage all of your cardiologists to look for this, to order that test, genetic testing, and look for this? And are there any, barriers to that genetic test imposed by the payers?
So that's a very, very good question. That's actually a good topic for a more in-depth discussion. But in brief, so from a personal standpoint, I think genetic testing for patients that have dilated cardiomyopathy is very important, and I'll tell you why. So it's actually interesting, I think, as a physician that, you continue to learn and grow as you go on in time. And I've, been part of the study now for a few years, and I feel like I've learned and grown quite a bit from it. And I'll kind of explain what I mean by that. So here at Cedars, we've enrolled 49 families with cardiomyopathy as part of this study, and the findings have been quite astounding. We've actually diagnosed about 7 new cases of cardiomyopathy in family members, meaning that these are our family members that came in that had no idea that they had, obviously they knew their relative had cardiomyopathy, but they had no idea themselves had cardiomyopathy, because when the ejection fraction is mildly decreased in that patient population, as I mentioned, with heart failure with mid-range ejection fraction, they very frequently asymptomatic. Those are people that have normal exercise tolerance because generally speaking, their heart has, minor functional abnormalities, but that's not something that's usually perceptible. So we, as I said, have diagnosed 7 new family members with cardiomyopathy, and those are people that not only were we happy to identify them, but those are people that we can help treat better because we get them on medical therapy, and we may save them, like you were questioning, from a heart transplant 10 years down the road because we're identifying them when their heart function is mildly reduced rather than 5 years from now when their ejection fraction is 20%. So I personally am very strong advocate of genetic testing because I think it gets the discussion going within the family and saying, hey, your other family members could be at risk for this. And so if you get tested and we find something, we can also test them, which is helpful. So I think the big message that I think for me is important and I think would be great to get out to cardiologists in the community as well is that if you have a patient that has dilated cardiomyopathy, screening and testing for the proband is a really key step that I think is often neglected that may help not only that patient but also his or her family. And I think that's really powerful.
Very good. We do have some questions now coming in. I don't know if Carol's mic is open. I think it is. Carol, if you want to, if you want to go and then follow up with her will be Rosemarie.
Okay, thanks, Keith. Yeah, Dr. Kranzdorf, that's a great presentation. A lot of new and interesting approaches to heart failure. I had a couple of questions, particularly with respect to sacubitril/valsartan. With respect to the guidelines, sometimes things vary a little bit. You mentioned in the studies that were done, they start with the 40% EF first and then went to 35%. Some guidelines from different payers and whatnot suggest that the drug should be initiated with EFs only less than 35%. Versus some may say less than 40%, and yet some clinicians, key opinion leaders feel like it may even be advantageous for that mid-range 40 to 50%. Can you comment on that?
Yes, that's a very good question, and a very astute question. So, so personally, I think there's a gradation. And anytime you do a study in medicine, and I'm sure you agree, the patients at the greatest risk also have the greatest benefit. So no question that your patient with an EF less than 35% is going to get the greatest benefit from starting sacubitril/valsartan. But I do feel that patients in sort of that mid-range ejection fraction may also benefit, especially, and I've certainly seen patients in that range benefit. I think the other thing is that there is new data from the Paragon-HF trial, which was a study of Entresto in HFpEF. And actually, it was interesting because it actually narrowly missed its primary endpoint. It was actually on the border of being statistically significant. So, and this was a population of patients with higher ejection fractions. So there probably is a heterogeneous subgroup in there that benefit. In fact, it was interesting in the study, there was some secondary analysis that suggested women benefited from this. So I think, in answer to your question, I agree 100% that those with ejection fraction less than 35% are going to benefit most, but definitely patients in mid-range ejection fraction may also benefit. I think the question is still, you can make the argument that they may benefit just as much from, ACE and ARB, titration to maximally tolerated doses and that sort of thing. But I think the medication can still have benefit in that middle range, especially.
Okay.
Does that answer your question at all?
Yeah, I think it does. I have two more quick ones, if you don't mind.
Of course, please.
One is, again, if you look at the guidelines, they suggest starting an ACE or an ARB first, seeing how the patient tolerates it, blood pressure response, et cetera, before then switching over to the SV combo. Do you see a role? I know there's some studies about in the acute hospitalizations, just starting off the bat with it. Does everybody have to start with an ACE or an ARB and then be transferred, switched over? What do you think?
Yeah, so that's another great question. So, I personally think I'm kind of a big believer in sort of, there doesn't have to be one right way to do things. So I think it's really up to people to individualize what's best for their patient. I think if you have someone who is, sensitive to medications or they don't have much blood pressure, then I think starting with an ACE and ARB to make sure they tolerate it is probably good. If you have someone that is, pretty robust and they have lots of blood pressure, then I think it's okay to start it right off the bat. I just usually start at the lowest dose to avoid sort of, making them, kind of hypotensive and that sorts of things. But I think either one is a very reasonable option. Obviously clinical practice is going to differ a little bit from the way that the trials are done because, people, as I'm sure you would agree, people who design trials, they're very smart and they know how to design them to be successful in many cases. So, I think always individualizing to your patient is the best thing to do. And I don't think there has to be one way to do it or another. I think there could be, depending on your patient, you could do it different ways.
Great, thank you. And last question, and then I'll stop.
No. Ask as many as you like.
What's on the drug combo? The EF, does it increase, and if so, is there an average, and is that associated, can we tell, with any structural myocardial changes?
So that's actually a great question, and there have been some small studies looking at that, and you're completely, I think your thinking is exactly right. For example, with beta blockers, we know that in general, the average increase in EF is 7%, although that's heterogeneous, and there's can be much more than that. And in general, the sort of the reverse remodeling effects of beta blockers in general tend to be more than has been documented in the past with ACE inhibitors or ARBs. Now, the exact average amount we have for Entresto, we don't have yet because only small studies have been done. There is one larger study that I want to say is like 400 patients that I've been eagerly awaiting the results of that hasn't been published yet. But I will say that, through the combination of, in my practice, I actually have a kind of a chart that I keep in my office and of patients who came to me with, EFs, between 10 and 20%, I have kind of a chart of 10 or 20 people's names. Usually I see every year, I probably see, 3-4 patients like this, where they came in with an EF of 15-20% and do use of a beta blocker, Entresto, a mineralocorticoid receptor antagonist. We see their EFs normalize. And I have quite a few patients like that. So, their medical therapy, the great thing about medical therapy is that it really works extremely well. And, I'm a really big proponent of getting people on meds, titrating up to maximally tolerated doses, because I've seen firsthand, time and time again, how much it can improve people's outcomes. And there's nothing I like better than taking someone with heart failure and making them not have heart failure.
All right, thank you very much. That's been very instructive. Keith, I'll turn it back to you.
Well, our next question was going to come from Rosemary Cannell. Is Rosemary's mic open?
Rosemary, we've unmuted your mic, so I think you might just be unmuted or you might be muted yourself. So Rosemary, if you want to unmute yourself, you should be able to share.
Hello, can you hear me?
Yes, we can.
Sorry, I don't have a question. I don't know how that came up. Hello?
Go ahead, Rosemary. We can hear you.
Okay.
Go ahead.
I didn't have a question. I don't know how it alerted you.
Oh, okay.
Okay, did not have a question. Okay.
Sorry about that.
Evan, let me ask you another question then it comes in. We've talked a lot about reduced ejection fractions. What about preserved ejection fractions?
Yeah, so heart failure with preserved ejection fraction is a little bit trickier than patients with reduced ejection fraction, just because, over the last 10 years, we have done study after study after study to find medications that specifically improve outcomes in this problem, and we have not really found any. Really, the only kind of consensus therapies that improve outcomes in heart failure with preserved ejection fraction are judicious diuretic treatment and then blood pressure control. Unfortunately, there's not really anything that is better than that. There was some signal for spironolactone in one study, so sometimes we use that. But we have kind of a street that's sort of littered with the kind of rejects of different clinical studies for agents that would be helpful in what we call HFpEF, but we really haven't found a lot that helps.
Okay. I do not see any other questions up on the Zoom webinar chat. If anyone has any, please bring them up right now. Otherwise, we'll put on deck the next presenter.
All right, that would be me, I think. Dr. Zaher again, wrapping up. Well, I want to thank everybody for joining. We had a great number participating today. I realized it was a long day and it was a little different than we were used to, but I think it was successful. I will vote for that. I just have a few announcements to make. First, the CMEs. We're going to get an email tomorrow or later about how to get CMEs for this presentation. The slides will be available also at some point. You will get a copy of those. Our next meeting, it will be in person at RAND on May 21st. And since that's month, it will be on women's heart health, the topic. So that will be interesting. And I think that's all I have to say. As far as my takeaways, again, I thought we had a really informative day. From the coronavirus, I would say keep following it because it's an evolving issue very quickly. Wash your hands, don't touch your face, and stay socially distant. From the diabetes perspective, again, almost half of the adult population with pre-diabetes and or diabetes. We have to figure out how to implement some programs that are really impactful, and something is, I'd say, simple but hard to do as weight loss can make a big impact. So we have to try to find those aspects of care that can do that and ways to implement programs. And in heart failure, wow, for a disease entity that's been, I'll say, somewhat dormant over the years with respect to new therapies. We heard today about some new and very interesting ones that are going to be beneficial in that sphere too. So I have nothing more to say other than, again, thank you. And thank you to everyone who participated in getting this Zoom meeting together. It was challenging, but I think we did it. Patty, do you have anything you'd like to close with?
This is Keith. I don't see Hattie listed up here. But
oh, you're right. I don't either.
yeah.
I think she's only participating by phone right now.
Okay, Alissa, is there anything you want to add?
Okay, I've been unmuted now. This is Hattie Hanley, Director of the Right Care Initiative. Thanks. It's challenging to work through all the new technologies, and I want to just really express my gratitude to all the physicians and team members who worked behind the scenes to make this a successful session. It was very much just-in-time learning, and we have to engage that just-in-time learning on this current pandemic. I do feel that many of the knowledgeable experts and companies involved in the Right Care Initiative will be very much the way we get through this with a lower inflection curve than what we've seen elsewhere. I have so much confidence in our leading edge thinkers in the scientific community. So just like what we just heard from Dr. Kransdorf, he's hoping that the best practices related to these medication combinations can get out into the hands of the patients to improve their outcomes. And that's a big part of what we try to do, is speed the uptake of the new knowledge. And I'm just wondering if we can, if we have any of our experts on the line who want to talk about ideas from other parts of their world that might be applicable to COVID-19. So for instance, I'll just mention that before I worked on heart attack and stroke prevention, I worked on a project for the state of California over a couple of years of hearings on improving infection control practices in hospitals, which, you know, thankfully we've made a lot of improvements in that regard. But one of the unusual findings was that patients who brushed their teeth 3 times a day in the hospital ended up with less pneumonia in the hospital. And so I'm just wondering if little pearls like that could be applied to reducing the number of COVID-19 deaths. So for instance, in addition to washing hands and staying very hydrated, what are other thoughts of people on the Zoom right now that might be applicable to helping to reduce the number of people who are sidelined or worse by COVID-19?
This is Keith. I'll take a first stab at that and just say, we really don't know enough about this yet. And one of the things that we need is a lot more testing to find out exactly, get a better idea of what the case fatality rate is, to get a better idea of, you know, how much the virus is out there in our society now. I think everyone agrees that it's out a lot more. The penetration of the virus into society has been a lot more than we've been willing to let on in the past. But until we know all of these things and can then further look at subgroups, you know, we won't be able to go any further. Why are children, you know, not getting sick like the older adults? It's natural that older adults with diabetes and heart disease are going to have additional problems. We're skating on thin ice already, and it just doesn't take much to push us through that ice. So, but are there other things? And that's going to come with better knowledge of the through testing of all who have this infection right now, and then we can dive further deeply into why some are getting sicker and why some are not.
So I want to just say that although the pharmaceutical industry is often roundly criticized in the press, all we can hope is that these amazing scientists who have developed these medications that Dr. Kransdorf was just describing, and, you know, everything from statins to all the other things that Dr. Kransdorf and other experts have presented on over the 12 years of our Right Care meetings, we know that we have incredible scientific capacity to make a difference. And what we need to do is slow down the, just like what we've done today, moving to social distancing to slow down the spread of the virus. That will give our scientists time to develop antidotes. And certainly we're a long way from a vaccine. But anyway, I just want to encourage our group and thank everyone for your passion for improving patient outcomes. We're very much hoping that by May 21, the coronavirus will have settled down and it will no longer be an issue. If that's the case, we will be meeting at RAND on May 21 for a half-day session on women's cardiovascular. And for the time being, we will have all of our meetings by this Zoom platform. So we're looking forward to getting your feedback on how it went and how you'd like it to go differently. And I just want to thank all of the speakers for your patience with our team as we did our just-in-time learning on using the Zoom platform for a session that has been extended across the state. And really, really appreciate your wonderful presentations and great teamwork to the Right Care team. Thanks, everyone.
Hattie, Dr. Brooks wanted to make a comment before we all sign off.
Oh, wonderful. Dr. Brooks. Yes, I was so happy to see you online. Dr. Brooks? Is he unmuted?
You are unmuted, Dr. Brooks, if you want to speak.
Perhaps he's muted at his end.
Dr. Brooks, are you muted on your phone?
I think we hear him coming in perhaps now.
He's on his cell phone.
Well, if he does, since he's unmuted, he can definitely chime in if he's able to. Are there others that wanted to make any comments? Dr. Peden, Dr. Kuo, Dr. Chen, any of our leadership have any final closing remarks? Well, once again, everyone, be safe, and thank you for hanging in with us for this 3.5-hour virtual meeting. It was really impressive and a great learning experience for all of us. So thank you.
Hattie, if you give me a second, I can get Oliver Brooks on the line. Just give me just a second.
Okay. So,
there we go.
Hello.
Oh, good. Hi,
right.
Dr. Brooks.
You're on.
Hi, and thank you. And I was on, but my computer doesn't have a microphone, and that was the challenge. So I just wanted to thank Bernadette for Mejia for presenting from Wops. A, the presentations were excellent. B, note that Hattie and myself are on a hypertension call. I hope you mentioned that, Hattie, in the meeting in terms of that initiative from the CDC. And lastly, as of now, Quest will accept tests directly from your doctor's office or health center. Before, all the tests had to go through LA County Department of Public Health. But as of now, I don't even know, maybe as of yesterday, maybe, any test for COVID-19 can be submitted directly to Quest. And that's a change from literally a day or two ago. Everything had to go through the county. So I just wanted everyone to be aware of that, of all of that, quite frankly.
Thank you. Thank you. And yes, I did mention the CDC call very briefly during the statewide announcements at the beginning of the Zoom session, but I didn't elaborate on it, and I would be pleased if you would like to do that, Dr. Brooks.
I think that it's just importantly that we, the Right Care Initiative, is part of this national collaborative with the CDC, and they're separating into different cohorts, work groups, and the fact that we have the ability to affect change. So I won't elaborate on it any more than that. We're at the end of the meeting. I was present during the whole meeting, but just was unable to speak.
Well, thank you for bringing our minds back to that. One of the items that we did discuss on the CDC call yesterday is that hypertension is, in fact, a very important comorbidity for those who are hospitalized for COVID-19. Of course, it's such a fast-moving research question as to, which came first. So it is I think an important moment for us all to re-emphasize to patients who need to be on the three, focused on their three control measures of blood pressure control, cholesterol control, and blood sugar control, should be encouraged through text messaging, emails, calls, etc., to stay with that regimen and keep active so that we prevent more heart attacks and strokes and to lower the impact on our health system right now, which is having such a surge of need. So we don't know whether the data that we're seeing out of China on the comorbidities of hypertension being number one, diabetes, and coronary artery disease is accurate, but it's certainly an important signal. So keep up the great work, everybody, and please take care of yourselves in this challenging time. It's wonderful that we can communicate through this, keep our collaborative going through technology, and I appreciate that we all have gotten to know each other over the years and have this new capacity for enhancing our distance communication.
All right.
Any more
Thank you,
questions,
Hattie.
or we'll sign off? Okay. Any further
Bye-bye, everyone. We'll either see
commentary from leadership?
We'll either see you in May or we'll hear you in May.
Excellent.
Correct.
Okay, thanks, everyone. Take care. Bye now.
Bye-bye.
Bye now.